For us to proceed with the program. And there'll be a slight change in order in which the program, what we have on the program, again, because one of our presenters is supposed to be coming in from Mars, the flight has been delayed a bit. So we want to shift things around a bit. So we'll start with Cecilia. So say what we'll be starting. I call Cecilia to come and introduce the chairperson. See, we have quite interesting topics for today. All thank you.
Thank you very much. For each of you, let me know that Madam Chair, I wouldn't say I wouldn't have to today. She's a very good mother. Sorry. Had the ABC prestigious Dr. Sari has a lot of interest in diabetes. She was one of the people who helped set up the National Diabetes Management and Research Center. Dr. Sari has been instrumental in the society from the very beginning to where we are now. She has a lot of passion in mentoring younger colleagues. We are grateful to come and share sorry, this morning. She chaired yesterday very seriously. And this morning she will continue to do that for us. And so, ladies and gentlemen, of course, shall we welcome our chairperson for this occasion. Thank you.
Thank you, Cecilia. As an adult physician, one would wonder why I'll be interested in pediatric medicine. But we're all children once. We are all mothers or potential mothers. We are grandparents. I'm a grandparent. Children with type 1 diabetes can experience various behaviors, including irritability, fatigue, and mood changes due to fluctuating blood glucose levels. Younger children who can verbalize their feelings, tantrums, or aggression when their blood glucose is high. Children and adolescents are also at higher risk for emotional illness like anxiety and depression. So if you have a child, grandchild, or someone whose child is being children, social withdrawal and disordered eating, the early signs and symptoms of changes, difficulty communicating, fear of distress, and tantrums, aggression. There's a higher risk of emotional problems, higher risk of anxiety, depression, social withdrawal. Some children may feel lonely, highlighted very these 40s.
FDA and other guidelines recommend that in the initial stages, we want to start with metformin. But you can agree with me that sometimes the metformin monotherapy alone may not be enough to control the sugars of the patient. So the guidelines recommend that we do a dual therapy. And in the case of Get Pharma, we have what we call Triviamet. So Triviamet is a combination of metformin and sitagliptin. And as you can see, this is one of the most powerful combinations that we have. In terms of HbA1c drop, we've noticed on paper and in practical of a difference of 1.24% in as little as 3 to 6 months. And this is very remarkable. Our doctors are very happy with it. We have the Triviamet 50 by 500 and the 50 by 1000, all at the discretion of the doctors and probably to be taken after food. You can also bear with me that when dual combination therapy alone is not working the magic for us, the guidelines allow us to add on a third agent, especially being an SGLT2. And to have a very good one here, Get Pharma introduced the MPGET, and precisely the MPGET 25 milligram. So MPGET is empagliflozin. And per the guidelines, usually the 25 milligram of empagliflozin is what is recommended to tackle the sugar levels for type 2 diabetics. So a fine combination of Triviamet and MPGET 25 milligram will be perfect for our patients. So MPGET, as we all know, is just a once daily dosing. And if you look at it in a broad scope, if you are doing just Triviamet, because of the little weight loss benefits that it brings, your patients who are type 2 diabetics and who don't necessarily need weight loss to improve their health outcomes, Triviamet will be best for them. If we go on the flip side, for our type 2 diabetics who may need some sort of weight loss to improve their health outcomes, we have a powerful combination of MPGET M. So that's empagliflozin and metformin. As we know how the mechanism for empagliflozin goes, osmotic diuresis of excess glucose. And we also know that excess glucose is stored as fat. So if we are excreting this excess glucose, we are assured of some form of weight loss. And we also know that there's literature supporting the fact that metformin can also aid in weight loss. So the combination of these two guarantees us of good sugar control and as well some sort of weight loss. However, we do not exclude the dietary modifications and the elimination of sedentary lifestyle. So if you want to tackle it from that angle, we go for the higher strengths, being the MPGET 12.5 by 1000. A twice daily dosing will give you the 25 milligram of the empagliflozin, which we mentioned earlier is suitable for type 2 diabetes. Then we can also have 2 grams of the metformin. Otherwise, there's 12.5 by 500 and a twice daily dosing will give us the recommended dose to tackle our type 2 diabetes mellitus. Also, if you have a patient who has heart failure and diabetes, we are not leaving you stranded. There's also MPGET M 5 by 500. If you do a twice daily dosing, you'll be getting 10 milligram of the empagliflozin, which is usually the recommended dose for heart failure, and you also be having 1 gram of the metformin. Obviously, if you do the 5 by 1000, a twice daily dosing, then again, you are getting your 10 milligram, which caters for the heart failure, and you're having 2 grams, which will help with the diabetes. So this is highly suitable for our patients and is able to reduce the risk of their hospitalization and death by a whopping 30%. And this has helped our patients a lot. As if that was not enough, we brought another 2 powerful combinations of MPGET LT, that's empagliflozin with linagliptin. And as you can see, the only newcomer there is the linagliptin. So this we reserve for type 2 diabetics who are renally impaired, which means that they cannot tolerate metformin because of their eGFR. We know per pharmaceuticals that if the patient has an eGFR of 45 ml per minute or less, it will not be advisable to proceed with metformin because of the risk of lactic acidosis. But we don't stop management. We do MPGET LT. So we have the 25 by 5 milligram. As we mentioned, 25 of EMPA is great for type 2 diabetes. Then we also have the 5 milligram of linagliptin. What makes linagliptin interesting is that it's able to bypass the renal excretion. So it's largely excreted through the fecal route and has all the renal protection that we need. So the combined effect of empagliflozin and linagliptin for our type 2 diabetics who are renally impaired will bring us massive results that we need. Also, for our CKD patients, definitely renally impaired, there's the 10 by 5 milligram. So that's the MPGET LT empagliflozin with linagliptin. CKD early stages, you are rest assured. Then also, if they have an EGFR which is above 20 ml per minute, we can introduce the 25 by 5 as well. Just a little caution, anytime you want to start an SGLT2, if the patient's entry EGFR is 20 ml per minute or less, it is not advisable. And that's because there's usually a 3-point decline in their EGFR when we start an SGLT2. That usually resolves in 4 weeks. So with our end-stage renal disease, we don't want to attempt any form of decline. So here we have it 10 by 5, 25 by 5, all at the disposal of our doctors, and this is a once daily dosing. So after that, we just trickle down to the plain MPGETs. That's just empagliflozin 10 milligram. So for your heart failure patients, highly sorted out. Also for your CKD patients in their initial stages, they are also sorted out with the MPGET 10 milligram. So some cautions we can look out for, as I mentioned earlier, the end-stage renal disease. If the EGFR is 20 ml per minute or less, we wouldn't want to introduce an SGLT2 inhibitor. Also not suitable for pregnant and lactating mothers, and it's also not to be used for patients who are less than 18 years or more than 85 years. Then we also want to encourage our patients to keep a high genital hygiene, because we know that as you are excreting excess glucose, it creates a very suitable substrate for microorganisms to thrive. So let's improve and reduce the microbial load by keeping a high genital hygiene. And we know that there's osmosis diuresis, so some water will be lost. So definitely want to tell our patients that keep your waters up, keep your hydration up at all times, and you will be perfectly fine. So in summary, I've given you the trivia meds for your type 2 diabetics who don't really need weight loss. I've given you MPGET-M, which is empagliflozin with metformin for your type 2 diabetics who need some sort of weight loss to improve their health outcomes. Also with heart failure and diabetes, they are all captured in the MPGET-M. Then for your renally impaired type 2 diabetics or your CKD patients, there's MPGET-LT. That's empagliflozin and linagliptin, which is a once daily dosing. Then for your heart failure patients, there's the MPGET 10 milligram. For your CKD patients, there's also the MPGET 10 milligram and the MPGET 25 milligram. So that brings me to the end of my presentation, and I would want to wish and hope and employ all our brilliant doctors here to join Get Pharma in the fight to tackle heart failure, diabetes, and CKD, and we'll have very perfect outcomes for our patients. Thank you very much. My name is Andy Kobna Eason, and the company is Get Pharma. Thank you.
Are they allowed to ask questions? Okay, 5 minutes for questions.
Just 3 minutes.
3 minutes. Okay, cost.
Okay. Okay, so please announce that with all our medications, none of them are above 400 cedis. So if you take the trivia meds like this, the retail price, if you are doing a twice daily dose, it will be about 350 to 370 cedis. If you take the MPGET-M, which is empagliflozin with metformin, the highest, which is 12.5 by 1,000, if you're doing a twice daily dosing, that will be 400 cedis. So all the strengths below are below 400 cedis. The MPGET-LT 10 by 5 is 230 cedis, and the 25 by 5 is 280 cedis. That's a month supply. Then with the MPGET 10 milligram, that's 260 cedis. And this is available in all our major pharmacies, being ECPL, Unicom, Top Up, Ad Pharma, Palace, Paramedica, West Point, and Unicom. Thank you.
Any other question? Okay, I just wanted to make a small comment on the AGFR of 45 and no metformin. So we reduce the dose if you're on 1,000 to 500. If it's 30, then we don't give the metformin. Thank you.
Thanks.
Are there any comments, questions? Okay. Okay. Thank you very much.
Okay.
So the next one, I have my paper here, sorry. Thank you very much. So we would have Dr. Minu. Please hold on. Oh, you can stand and then we'll give you a nice intro. She did a very good job with her presentation yesterday.
So Dr. Ira Abena Meno is a pediatric endocrinologist with over a decade of experience in managing diabetes, childhood endocrine and metabolic disorders. She leads pediatric endocrinology services at Kolebu Teaching Hospital, where she has pioneered improvements in diabetes care, not only in Kolebu, but across the country. Her research and advocacy endocrine care in low-resource settings. Dr. Menu is passionate about mentorship and capacity building for pediatric endocrinologists in Ghana. She holds an MPhil in pediatric endocrinology and metabolism from the University of Cape Coast, South Africa, Cape Town, South Africa, and is a fellow of West African College of Physicians. Dr. Menu, you're welcome.
Thank you very much, Madam Chairperson, and good morning again. So today we're going to look at overview of diabetes in children, and my other colleagues will continue on how to manage and diagnose children with diabetes. I have no disclaimer, but then I'm a pediatrician, so my slides, yesterday I think we listened to the OBGYN and it was just plain slides, but as a pediatrician, my slides will have a lot of cartoons and a lot of colors. And I'm passionate about children living with diabetes. Before we move on, I know there are a lot of adult physicians here, so I'm going to get you all comfortable because this morning some of them kept on saying, we are here to support you. You are not just here to support us, you are here to be with us and learn a lot. So I'm going to get you all comfortable by starting with this case for us to just get into it. So you meet a 58-year-old man who presents with shortness of breath and fatigue. Physical examination reveals bilateral basal crackles, mild ankle edema, elevated jugular venous pressure. ECG shows non-specific STT changes. What are you thinking about? Please take off your endocrine hats. What are you thinking about generally? Heart failure. Yeah, thinking about heart failure. Okay, so provisional diagnosis will be heart failure. You're going to start furosemide and aldactone and all that. 2 days later, you realize that symptoms have only slightly improved. The patient looks anxious and very restless. So during ward rounds, you decide to take other history. And I think in the morning when we're sitting down, we're talking about how some medical officer can be with a patient for 10 days. And then the consultant walks in and some history is now dropping. Okay, so you decide to take further history. And this patient tells you that recently they've been on some new medication and the cardiologist put them on amiodarone about a month ago. Does this change your diagnosis? Now endocrine hats on. Does this change your diagnosis? Pardon me? Certainly. So what are you thinking about now? The amiodarone has caused what? A high output heart failure. So you're going to request for thyroid function test, and then it's going to come up, and then the patient has something going on. So only 10% of the history was missing, but then we made diagnostic error. So sometimes 10% does make a lot of difference. And we always say that type 1 diabetes is just 10% of the whole diabetes population. So usually we are down there. But then from the medical point of view, 10% does make a lot of difference. So you are not here to support us. You are here to listen to us and make a change. Thank you. Okay, so my main aim here is to start. I don't know whether this has already been going on, but to start or restart or intensify the conversation on getting a diabetes register. I'm going to talk about epidemiology and I'll let you know why. And to inform you guys that we're keeping the children alive, so they're going to come to you. So you need to know about them. And very soon, they're going to be a working class of people who've been living with diabetes for 10 years or 20 years before they start working. And yesterday, as I listened to the obstetricians, I was just wondering, oh, these children who are being diagnosed at 9 months, 10 months. So their whole life is going to be a burden of problems, even when they become pregnant, okay? So we need to really know about them and know how to take care of them. Okay, so this will be my overview. Just go through these things. So we know what diabetes is. And in children, it's as a result of autoimmune destruction of their pancreatic cell. And also we know that the target tissue resistance is cropping up in children. It's the most common endocrine disorder in pediatrics. And the incidence is increasing. Adults is increasing. In pediatrics also is increasing. And 5 to 10% of all diabetes cases are actually type 1. Under the age of 20 years, type 1 does account for 85% or more, but the others are also happening. So when we talk about type 1 diabetes, there's variation in epidemiology across the whole world, and the age at which is developing is actually coming down. Previously, it used to be around the pubertal age, but now we realize over the past 2 decades, it's happening in the younger generation. And I think in Kolebu, the youngest we've diagnosed so far was an 11-month-old child. So Finland continues to have the highest global incidence of 64.2 per 100,000. So in the recent IDF Atlas, and I think we all know Graham who pioneered it, you see this graph, and it's not really showing well, but then Finland is on top. And when you look at the 85 countries that did represent their data, in Africa or around us, you can see is Mali and Burkina Faso. You can't see anything from Ghana, but I think we can do better. So this is just to highlight that we might be seeing them, but we are not projecting it globally, and we need to start thinking about it and projecting it globally. Then there's this youth onset of type 2 diabetes, which we know from yesterday guest speaker's speech, we know that it's also creeping up. And type 2 diabetes is a metabolic disorder in which the body's response to insulin is reduced. The youth onset of type 2 diabetes is actually a lot more going on. So there's genetic, there's environmental, and also a little bit of metabolic causes. And the epidemiology of it is different because we all know that some children will be fat, but then they won't get the type 2 diabetes. Some people will be, but then they will not be, but they'll get the type 2 diabetes. In the early 1990s, it was just some case reports that were being published then about young children getting type 2 diabetes. Then the Search for Diabetes study, which was done or which is being done in the US, was started in the 2000s. And as of 2023, their data showed that there has been a double in the number of cases of type 2 diabetes that they are seeing from 9.0 to 17.9 per 100,000 person per year. And it's mostly in the females. Okay, and this is not different from the data that they are reporting from Europe as well. There's a threefold rise. Okay, so aside obesity, we know that obesity is also in the increase. There might be something else going on. But then you ask ourselves, is that what we're seeing here? We don't have any data to prove, so we are not sure what's going on. Then another bit that we don't really think about, that happens also in the pediatric group. It's quite rare, but it does happen, is the maturity onset of diabetes in the young. So usually it's after a while, then you, like your diagnosis or you see the patients and then it starts clicking by something that I want it to be in our mind because it happens in those less than 25 years, okay? There will usually be a strong family history of diabetes. And the parent that is affected will have a first-degree relative who also has diabetes. And the age of onset will decrease as the generation goes down. So maybe grandmother will have diabetes and grandmother would have had it around 40-something. Mother will have diabetes around 30-something. Then you'll be seeing a teenager who has diabetes. You should think about the maturity onset of diabetes of the young. Their BMI, they are not obese. Their BMI usually less than 85th percentile. And then there is absence of risk factors. So this one is as a result of a genetic mutation, usually a single genetic mutation, and there are a number of them. So there are about 14 types or 13 types. And sometimes there are some things associated with it. So if you think about it, then you can go investigate for the rest. Okay, so if you talk about MODY5, they usually have genital abnormalities. They usually have cysts. So if you are diagnosing somebody and you think the person has a maturity onset of diabetes in the young, then you can go and investigate further and you might help another relative who has a renal cyst or something like that. Then there's the MODY2. So these ones, usually they don't come in. Maybe they are picked up during antenatal. when they do the OGTT, because they don't have any complications from their diabetes. Their HbA1c will be sitting around 7.2, 7 point something, more than 6.5, and nothing really happens to them. So if you think about it, you know about it, then you know what to do. Because yesterday with the presentation, they're like, if they do the after pregnancy, your HbA1c doesn't come down, then you are now classified as having diabetes already or evolving diabetes. But these ones, they will be lost to follow up. You see them, you reprimand them. Nothing is really happening to them because what they have is MODY 2 and nothing really happens to them. But once you know, then you'll be able to manage them appropriately. And those who've had history of neonatal diabetes, okay, so once they have neonatal diabetes, some of them are transient, so it will go away. But when it goes away, you need to always remind the parents that they need to be on the watch out because it can't come back again. So that is the maturity onset of diabetes in the young. It's really rare, but it does happen. And there are some places that they do the genetic testing free. So if you pick up a patient like that, you just have to go on the Ezeta platform, and then you take the sample and you take it to them and they run it for free because they are trying to put a data together. So the risk factors for the youth onset of diabetes, type 2 diabetes, these ones we know them, sedentary lifestyle. Now, most of our children, the schools are all just buildings. They don't play. They're just sitting down. They come home. A car will take them to school. A car will bring them back. They enter the house. They just sit in front of the television, and that's all they do. So overweight is on the increase. Intrauterine exposure to maternal gestational diabetes. So the obstetricians need to tell them that you need to be on the watch out for this, your child that you've exposed to diabetes, maternal obesity, family history of obesity, and social factors. These social factors go from like the kind of low middle income that we say we are. So now we think we have money, so all we do is junk food. This is what we are putting our children at risk for. Okay, so I move into the epidemiology bit. So this is where I got stuck. I'm like, epidemiology, come and give you things that are on the net. Will it really help us? We don't have a register, so I got stuck here. But I'll give you a little bit about global statistics and I'll see what I can do with the rest. Okay, so the incidence of type 1 or type 1 diabetes in 2025, it's been estimated that 513,000 new cases will be diagnosed this year. And this is an increase of 2.4% from the previous year. And of this, 43.3 are estimated to occur in those less than 20 years. Okay, so these are global statistics. So you ask yourself, what is happening to us, our local data? We have no national register. We still have challenges with diagnosis. There's a bit of diagnosis dilemma. And then there is a huge poor health seeking behavior. Once you diagnose someone, you tell them that they need to be on insulin for life, or God forbid, they go see the pastor, they don't come back. You've given them very, very bad news. They don't want that. Okay, so this makes it makes getting the data really very difficult. So we can't give an incidence rate of what is happening here. We can't give a prevalence rate, but then I can maybe tell you something that can get all of us thinking. Please, we need to think. Okay, I'll be able to give you the total number of patients that are seen in Kolebu and what has happened to our... It's back. Okay, and the total admissions over the years related to diabetes. Okay. So from January to end of September, I couldn't add October because of LIMS. We've had 32 admissions in our ward related to diabetes, and 47% of them are new cases. So that's the incidence rate at a very small percentage, like over the whole of Ghana. But that's our incidence rate, and 90% of them are females. So we know that type 1 diabetes is actually autoimmune, and autoimmune diseases supposed to have a female predilection. But then when you look globally, there's this male to female like equal thing, but it looks like in our setting we are having more females. Is that it? We can't tell. The age range has been between 3 and 17 years, and the median age is 13 with a mean age of 12 plus or minus 2. So there's a graph showing that if you go back into epidemiology, there are some studies that I've seen that sometimes they think that there's a higher incidence that occurs around winter. But then we have the dry and then the rainy season. So if you look back, you realize that in January, we didn't get any new cases. So, and then in June as well. But in September, we had the highest number of new cases. So we had 5 new cases coming in. I must say here that these are the people that we want to refer to Korle Bu, because there are other pediatricians in other parts of Accra. Sometimes when they call and they can manage, they manage them there. But these are the ones that came in Korle Bu. So the 5 is not for the whole of Greater Accra or anything like that. Okay, so now let's look back to 2024 and see if there's a pattern. Okay, so in 2024, the whole of 2024, we had 33 admissions. So it looks like this year we've had more admissions, because we are just, that one was up to September. So the whole of 2024, we had 33 admissions and 39% were new cases. And also the more females. So the more females seem to really be a pattern. And the age range is the same, because that's what we admit, with a median age of 11 years. So there's a pattern also. In January, we still had some new cases. The new cases are the blue one. The new cases are the wine, sorry. In January, we did have some new cases. But then in September, if you look at September, we didn't have more new cases, but we had old ones coming in for admission. So when I compare the graph, there's no pattern. But this is just for 2 years. So if we go back and back, will we get a pattern? We can't tell. But a register will help us solve the problem. So I'm looking at DEMSoG executives. I hope you are taking note of this. We need a register. Okay, so 13 newly diagnosed pediatric cases in 2024. 15% were labeled as type 1, type 2. So when we label them as type 1, type 2, it means that they have signs of type 2, but then the glucose is so high. So sometimes we give them that label, and as the disease progresses, we'll be able to clearly tell whether they are type 1, type 2. This is because we can't do antibodies, and we know that in the African setting also, the antibodies sometimes are negative. So we label some of them as type 1, type 2. The median age is 9 years for those that we've diagnosed this year. And I think I've said this before, this is not reflective of the whole country. So let's move on to prevalence. So the global data shows that 9.5 million people will be living with type 1 diabetes by the end of 2025. 2021 was 8.4, so that's an increase of 13%. And 20% of these are between the ages of 0 and 19 years. So the general thing is 20%, so that's a small percentage, but we learned earlier in my first slide that 10% makes a lot of difference in medicine. So this is not half full, half empty kind of thing. So though it's 20%, we need to know about them. So in lower income countries, the number has increased by 20% from 2021 to 2025 because we are diagnosing them more, our population is growing, and also there is a reduction in mortality, because now we are treating them better. However, for the type 1 diabetes Ghana index, which is a estimating tool that they use for you to project how many people are going to be diagnosed and all that, unfortunately, the healthy years of a 10-year-old child diagnosed with type 1 diabetes is just 23.8 years, which is really sad. We need to really do more. So local data. So this global statistics I've given you. Move on to local data. So the total number of patients regularly, so I'm stressing on the word regularly. So some of them do come in, they don't come again. So if I say regularly, these are ones that we've seen over and over and over. They've come for review and all that. Regularly being followed up in the clinic, the diabetes clinic, is 82. And 10% of them are labeled type 1, type 2. I really don't have any type 2 in my clinic because I guess most of them are adolescents, and usually I move them to Dr. Banker's clinic or the adult clinic. So I don't have any clearly type 2 in my clinic. Majority of them are adolescents, and this is early adolescents, so not late adolescents, 74%. And it's not reflective of the whole country, and we need a diabetes register. I think I should have just cut this and posted it like every slide, repetitive. Okay, so how do they present? I think Dr. Sari made mention of the 4 T's. In children, we really use the 4 T's because it catches their attention. Okay, so the toilet, the thirsty, being tired, and being thin. So the polyuria, polydipsia, all those things are there. But for the children, when you use the 4 T's, it really catches their attention. So we really use the 4 T's a lot. But then it's still the same thing. So the toilet is not the number 2 is they are going to pee. pee, being thirsty all the time, unexplained weight loss, and being tired. So their battery is just running low, which comes with the irritability and all that. If these things are not picked up, the rate at which they progress to the emergency is quite fast. So they can come in with DKA or HHS. So the HHS will be the maturity onset of diabetes in the youth, or the youth onset of type 2 diabetes. Okay, so we're still seeing them coming in like this. So the classical 1900s description, very thin with all the classical presentation. But then sometimes we see them like this. They will still come in and then they'll say there's a weight loss. And the weight loss is looking at you with a BMI under +3. Okay, so this is what we are seeing in the 2020s, okay? And sometimes because of the type 2 diabetes, there will be slow healing, which you need to think about, always constantly tired or blurred vision, plus or minus weight loss. So don't wait to be seeing them like the 1900s. Please, they come in like this now in the 2020s, okay? And sometimes it's actually an incidental finding. So that's how come we are not getting a lot of DKs coming these times, because the mothers will just be alarmed, and maybe the mothers are diabetic themselves and they decide to check their sugars and they realize it's high. Okay, so you can see this coming very obviously weight loss, or sometimes you can see the acanthosis nigricans. So in the children, we look out for it. You can see the very obese ones, sometimes they don't have this. And there is an element of weight loss, and it's obviously a type 1, not a type 2. Okay. So I'm just going to go through 3 patients that I could remember when I was making the slides and how they presented. So patient NA came in at 9 years, 4 months with a classical presentation, but had abdominal pain with vomiting. And the BMI was 16 kg per meter squared and was dehydrated. The RBS was very high with serum ketone of 4. So was in DKA, and the diagnosis of type 1 diabetes was made, was managed for the DKA, started on basal bolus, is doing well and being followed up in the clinic. Then patient KB came in 15 years, 2 months, a little bit of weight loss here and there. Mother is diabetic. Her mother had been checking the sugars for 9 months and the sugars were high. But then she was just monitoring. Came in with a BMI of 28 kg per meter squared. So quite big with some acanthosis nigricans. RBS at that time was 18, but what has been living for 8 months with high RBS that they had not done anything about. Serum ketone was 0.8, was labeled as type 1 versus type 2. I asked them to do the C-peptide and all that. They didn't do it. Someone made a mistake and started on insulin, so we decided to go by basal boluses and metformin. And she went to SS and she decided to stop all her medication. And she was checking her sugars and she says they are now well controlled. She's been lost to follow up. She came back when she came home, came to show me the book that the sugars are well controlled without any medication, but she's been lost to follow up. I plan checking up on her this Christmas, calling her to find out how she's doing. Then there's patient NDS. This is a recent admission, came in at 1 year, 10 months, so quite young, an adopted child with polyuria. Mother can't tell whether much of weight loss, but the child was very lethargic. And I think Dr. Asari said this morning that sometimes the children would be very irritable and everything. You need to just check their sugars. Was moderately dehydrated. Weight for age was less than the -2Z score. RBS was high, but serum ketone was 1. So wasn't in DKA. So we didn't manage as that, just hyperglycemia in a newly diagnosed type 1 diabetes. Was started on basal boluses, and we are following up keenly at the clinic and doing well. So these are how they present. Okay. So we talk about screening. Do we screen? Type 2 diabetes, they screen. Diabetes in pregnancy, they screen. In type 1 diabetes, should we now be moving on to screening? I think so, but do we have the logistics to do that? Not really. It's important because it will make you detect those who are at risk, because you pick up the antibodies. So you can monitor them until they come in with clear symptoms or type 3 diabetes for you to start insulin. So these are the antibodies that have been noted. So you have these antibodies developing before antibodies against the pancreas cells before the diabetes starts. We all know the pathophysiology, but I think one of my colleagues will be going through the pathophysiology. Okay, so this will help us to avoid DKA, because places where they do it, incidence of DKA has actually been reduced from 30 to 60 to 5. So it really does help, and it prepares the family for what is ahead of them. Okay, so when they screen you are positive, they will monitor you periodically. And then I think last 2 years, we all heard about teplizumab. So this tends to delay the clinical onset of the disease for about 2 years. So while this is delaying the clinical onset, at least the whole family will get used to it. So teplizumab is available. So we can be screening them, but I don't think we are ready yet. But the youth onset of type 2 diabetes, that one we should be screening once they get to puberty or after 10 years. So at every point in time that they come to the hospital, just make it a point to just check their random blood sugar. More so if their BMI is above 85 percentile for age and sex. And there's a family history of type 2 diabetes, first or second degree relative. And if you have any clinical signs, like if the person has typical acanthosis or fatty liver disease, so once they come to the hospital, just make it a point to do a random blood sugar for them, or they are on any antipsychotic that's making them gain weight rapidly. So these are recommendations from the International Society of Pediatric and Adolescent Diabetes, which I keenly follow. Okay. So how do we diagnose? In most cases for children, they will come in with a typical presentation, or they will come in DK. So it's actually very easy to diagnose in children. But then now, because people are becoming aware, advocacy is really going on very well and people are aware. Sometimes the mother will just say that she thinks the child is peeing a lot and then doesn't have that other classical symptoms. So you can decide to do a fasting plasma glucose or blood glucose after an overnight fast. And 8 hours is okay because you don't have to want to fast the children so much. If it's just sitting at borderline, you are not sure, you can repeat in 24 hours to be sure. Or you can do a postprandial value of, it doesn't have to be the 2 hours like the gynae people do. So any random blood sugar more than or equal to 11.1 is used. And if it's just sitting at 11 or 10, you want to be sure you can repeat at least 24 hours. Okay. However, if you do a random blood sugar and then there's the classical symptoms of the 40s, then it's obviously the diabetes that you're dealing with. Or you can decide to do the HbA1c, okay, which more than 6.5%, the same. The OGTT is not really recommended. I mean, you can do it in the child, but it's a little bit cumbersome to do it in the child. So not really, that's how come I put it in red. But you can do it in the adolescents ones, like those with the type 2 diabetes. You can't do it in them, but it can be very cumbersome in the pediatric age population to do. So for the youth onset of type 2 diabetes, you want to do the insulin level, the C-peptide, and it's usually high. But remember to do it before you introduce an exogenous insulin. And the autoimmune markers, when it's absent, sometimes you want to classify them as type 2. But remember that there are 4 to 5 autoimmune markers. So which one are you doing? And there are some that if you don't have, it's not here nor there. The sensitivity and specificity is also not so strong, and they're actually very expensive to run also. So I've put a question mark there. And then also the lipid profile, if they come in and the glucose is very high and you do your lipid profile and it's high, it's not because of the high glucose level, is not, you can't really say that there's hyperlipidemia also. So this is actually a diagnosis of exclusion, and you need to make sure that you've ticked all the markers before you say clearly that it's not type 1 and it's type 2 diabetes. Okay. We all know DK, so I think I'll just zoom in here. But we should know that it's a common presentation in children with newly diagnosed diabetes. We are really trying to move away from this so that it's not a common presentation, because the mortality can really be high and we don't want this to be happening. Okay. And the frequency varies. So in some places 12.8. I think now in recent times, UK moved from a very low incident rate to, I think it's not really high, it's in the 30s, but then they are up. They are so worried, and there are so many things that's going on, increasing the advocacy so that they reduce how many patients come in DK. And when I see things like that, I'm just wondering that if they know what happens in sub-Saharan Africa anyway, but they have the means, so they need to do it. So for 2025, the frequency of DK at presentation in Kolebu for the past 5 months, sorry, it's 5 months, is actually 36%. So this is actually low, but then I must say here that it's low because sometimes our DKs are managed externally. Okay, so if there's a pediatrician somewhere, they'll manage the DK and they will then bring them in. Okay, I'll be ending soon, so I just want us to now, I raised your blood pressure up, I want to bring it down. So you see these words here, and most of us are endocrine people, so you are familiar with these words. So just look at them, and I want you to, sorry, oof. Please can we go back, sorry. Okay. Please can we go back? Back. Okay, all right. I want you to take one big word and one small word and describe what your day usually is like. As an endocrine, what are the things that you hear most or when you go through the day? Dr. Asari. Good for you. Dr. Ade. Should I cut?
So I should pick one big word and one small word. Okay, so I'll say balance and diabetes. Balance because most of the time people say, oh, I hear you are an endocrinologist and you deal with hormonal imbalance or problems with hormone balance. And of course, as for diabetes, I have a whole clinic. The whole of Wednesday, I sit in the diabetes clinic the whole day. So those are the two words.
Should I move on to the female? You also have an endocrine person. Insulin and glucose. So if you want to know what my two words are, you see me after the presentation. Okay, so this is our team. I am the diabetes clinic in Kolebu. We meet on Tuesdays, except, for 2026, wouldn't be meeting on the first Tuesdays of the month. And I think the picture here is when I started the clinic somewhere in 2017. It was a small clinic, and now I have 80 people to manage. And I've gotten the whole of the R2s residents, the second year, now third year residents in Kolebu to try and help me with advocacy in diabetes. And that's the picture down there. Okay. So I'll end here. If you have any question, you can ask.
Actually, you finished 8 minutes before. So I think if anybody has got any question, you can ask.
Thank you very much, Dr. Menu. Excellent presentation. A fine pediatric endocrinologist. I did my pediatric endocrine rotation under her, so I know what I'm talking about. Very fine, doctor. You talked about screening, and of course, screening with question mark. Unlike the adults with type 2 diabetes, where we can do a lot of screening and there are clear indicators for the screening. When it comes to type 1 in the children, we are in a gray area. I'm bringing this up because, of course, previously the question would be, you are screening somebody with type 1 diabetes so that you do what? But now with the advent of teplizumab, at least we can buy some time. It's not a lot, but I think if you can prevent somebody from getting diabetes that will be treated with insulin for 2 years, at least you've done something. So my issue is really for those who can afford. Of course, I have patients, they do the C-peptide, they do the anti-GAD, the IA2, they do it. It's expensive, but there are people who can afford. So what would make me look for a particular group of children and screen them? That is assuming they can afford. I'm not talking at the national level. I know it will be a challenge, like you said. If NHS doesn't pay for certain basic things, why would NHIS pay for antibodies? So I want to know, for the small subset of people who can benefit, what should we look out for? How should we select them to screen them? Thank you.
All right, thank you. So there is a little bit of genetic components when it comes to type 1 diabetes. And I can't remember the values at the top of my head. But then if there's a sibling affected, there is a small percentage that another person can be affected. So if you have a family that there's one person, a child affected with type 1 diabetes, the others can go and do the antibodies, and then you'll see. Also, if monozygote twins and dizygote twins also, there is this percentage, okay? So based on the percentage, so once there's a family member who has type 1 diabetes and they can afford, I'll advise that they can go do it. There are few families that I know that they have 2 or 3 children who have type 1 diabetes. And I think there are 2 families like that in Ghana that I know, that 2 of their children do have type 1 diabetes. So.
Thank you, Dr. Meno, for the good work you are doing with the type 1 or the children with type 1 diabetes. So because of the free insulin program for the children, pretty much all your patients are on the ideal basal bolus. They do the basal with the boluses. When you look at the adult side, the current adult type 1s, or either diagnosed at the end or transitioned, most of them are on, have switched, either they were started on Mixstart, twice daily premix, or they started off with basal bolus and are now on, either because of cost or the complexity of the whole regimen, they're working now, they just can't. But the mitigating factor is cost. And the reason why you're able to do it in the children's course, the insulins are free. Just recently, someone was transitioned to the adult side because the insulin is not free now and can't afford it, so it's now on twice daily premix. So what's your going forward? How are we going to sustain this? Because that's what they need ideally. But then because of cost and other mitigating, they're switching and they'll have to switch to premix, which is not.
Okay, so the program actually covers for people up to 24 or 25 years. So when you see them at the clinic, just give them the prescription and let them come to the pediatric side for their medication. So it will take them for some years. But then again, after diagnosis, after the first 2-3 years of diagnosis is where you really need to have a tight control. And when you have a tight control, it will really help cut back on your complication risk. So, that's another angle that you can look at. But the program covers up to 25. And then you also said the complexity. So it's actually very simple to be on basal bolus and be working, because all you need is your basal. Then as and when you are ready to eat. But then if you do the premix, it means you are supposed to take your breakfast and supposed to take supper. Yesterday, I overheard someone saying, that's my last meal when we're having lunch. And that's actually the person's last meal. So if that person is diabetic, doesn't have to inject again. Might have had the basal, just inject in the morning, inject in the afternoon with a meal, and done. But then if you're on the pre-mixed, then you are forced to eat at supper. So if you explain these things to them and you let them know that, it might sound like it's a lot of injection, but at the end of the day, it's the flexibility. The flexibility really, really does count. So as a worker or as somebody in university, you don't want to, in the morning, you have to by force eat because you need to inject. You can decide just to move around, just get your basal and move around. That's when you are ready to eat, you inject. Okay, but the program is covering up to 24. So till they are done with university and they start working, it's covering them. Just give them the prescription and let them come to the pharmacy.
I think in support of that, I have a couple of university students in my clinic No, they actually get them for free because I send them to Betty's clinic.
Yes, yes.
So they still, we
Yes.
can send them to them.
So you will still see them, but just let them come to the pharmacy and they will be supplied.
Okay. I have a question. What, the teplizumab, how much is it? Or it's free? Oh, it's a question. Why? Affordability is a problem.
Please, I have no idea.
You have no idea?
No, I have
Thank
not
you very
checked.
much. Okay, and then I'll throw back the diabetes register. We'll work together and get a register.
Yes,
So you're a very
absolutely.
active member of DEMSoG, so we will work together and we'll get a register. Thank you very much. Any other questions?
I think what I'll say is DEMSoG should talk to National Health Insurance so they put the insulins on their list.
Well, Sanofi is working on something. At least for the basal, they are working on something with them. Yeah. So hopefully, yeah, we're still trying. Please, any other?
Thank you very much, Dr. Menu, for the presentation. It was very insightful. I wanted to find out if the screening is actually about doing the autoantibodies. And of course, we are LMIC. Is there something better we can do? Bearing in mind that we also want to get a register. Is there something we can do, maybe like diagnostic criteria, going to the schools, maybe running some of these very affordable ones, and then maybe picking those with abnormal values, and then maybe taking it a step further? Will it help us knowing that we are a low resource setting? Because if we are waiting to do the autoantibodies, then it means that we only catch those who can afford. So I don't know if it is something that is possible that we can do as a nation so that we can pick up these young ones very early. Thank you.
Thank you. So then it goes back to advocacy. So the 40s. So the school, so now Ministry of Health together with Sanofi, they've launched this Kids for Diabetes program. So the teachers are aware of it. And we all, as pediatrician or as churchgoers, whatever, we can just talk to people, let them know about the 40s. So once you know that a child is experiencing that, you check. And if the sugars are high, you can put them on the basal bolus even before they come in with DK. So that's what we can do. The other thing about the autoantibodies is that most of our type 1s that had money that could even do the autoantibodies, they were negative. So we don't know what type we have in Africa. So that's when then the register will help. Then we'll be able to know what can we really do. But for now, just advocacy, the 40s.
Just a simple, straightforward question. I saw one young guy, 15 years, 16 years, very big, was like 110 or so. In fact, I was almost convinced it was type 2 diabetes. And then the C-peptide, autoantibodies, and everything type 1, you know. So this issue of, what do you call it? Is it a double diabetes? What is your take on that? And I've seen quite a number since that one, you know, big, the 2020 model.
I have one who I also have labeled as ladder, who is also very obese, and autoantibodies came high, very high. So
yeah, you have answered the question, the
yes,
2020s.
thank you very much. All right. Thank you very much. I think the next one will be BI. If BI is here. No? Okay. Then can we have Novartis? Oh, hey. Sorry, I didn't know you work for BI now. Anyway, thank you very much.
Hello. Okay. So now I'm from D. And for the next few minutes, I'll be from D Nikwe. I'll start by presenting for BI. I think we've had very lovely discussions this morning about diabetes and then its problems in children. The register, I think, is a very major thing we should consider and maybe screen our patients beyond the diagnosis every 5 or 10 years for complications in terms of type 1 diabetes. Let's see at 10 years of diagnosis, how many of them have kidney involvement. I think it's a very major thing we should consider, because we may then know whether we should tighten our control or do what we are doing currently. So I'm going to talk about cardiorenal metabolism, translating guidelines into clinical practice. And I think we've heard about this topic in the last few years, a very important topic, because since yesterday's topic and this morning's topic, everything we are doing can culminate in these two. People coming down with heart failure and renal impairment if we don't manage them very well. So what's the definition of the cardiorenal metabolic syndrome? So it's defined as a systemic disorder characterized by pathophysiological interactions among metabolic risk factors, CKD, in the cardiovascular system, leading to multi-organ dysfunction and a high rate of adverse cardiovascular outcomes. I put that one in red for us to have the emphasis on this. Now, patients will come with metabolic risk factors like obesity, diabetes, dyslipidemia. If we don't manage them very well, over time they will get cardiac disease, they will get renal disease. And there's a bidirectional relationship between these systems. So these three can interact and you get multi-organ dysfunction with a very high rate of adverse cardiovascular outcomes. This is what we want to avoid. In all the presentations we had so far, we are trying to avoid this. Now, the American Heart Association stages the CRM into 4 stages. We have stage 0, where you don't have any risk factors, and then we have stage 1. In stage 1, you've developed excess adiposity, or you are overweight, or you're obese. Now, if you have that alone, that's fine, but sometimes you move from that to what we call dysfunctional adiposity. And in this case, you have pre-diabetes in addition to being overweight or obese. Then you can move from this stage to stage 2, where you then have frank diabetes developing, dyslipidemia, hypertension, metabolic syndrome, etc. And we pick most of our patients here. We must be picking them from stage 1. Then we can move to stage 3, where they have subclinical cardiovascular disease. Say somebody has hypertension with LVH, and that's subclinical CVD. Our last stage is clinical CVD, where patients come with heart attacks, strokes, heart failure. And this is the ultimate stage we want to avoid. So all the presentations, we want to avoid stage 4 CRM. Now, CRM has impact mainly on cardiovascular disease, and that's the greatest clinical impact. Our focus is to reduce cardiovascular disease and invariably reduce the survival that it also has impact on. But we shouldn't neglect its effect on the liver, on obstructive sleep apnea, and other pathologies. So CVD is the main thing, but there are other impacts of CRM. The individual components of the CRM, obesity, diabetes, and CKD, all have effects on survival. So if you take grade 3 obesity and your BMI is more than 40 and you're happy going about your everyday activities, your lifespan is reduced by 8 to 10 years just having grade 3 obesity. Now, same for diabetes. If you have diabetes, you have an average shorter lifespan of around 13 to 14 years. And if you have CKD, your lifespan is reduced by 20 years if it's stage 4 or stage 5 CKD. So you see, the individual components of the CRM reduce your lifespan. How much more when they are combined? And that's a very important thing that we have to focus on. The effect of the CRM is not only on morbidity and mortality, it also has effects on our finances. Just as of last year, over $1 trillion was spent on management of diabetes alone. Can you imagine that diabetes alone, there are many diseases in the world, I'm sure more than 100 diseases in the world, but diabetes alone accounted for 12% of all global health expenditure. So diabetes is accounting for more than like maybe 10% of all the other diseases that we have, and that's a very serious problem with respect to diabetes. Now in Africa, we are projected to have the highest increment in the next 25 years, a whooping 142% increment in the next 25 years, compared to Europe that is projected to have only about a 10% increment in the next 25 years. The global average is that there will be an increase in the prevalence of diabetes by about 45%. Because we are in this region, we must prepare for the complications and be able to manage them very well. Now, anytime you're at the clinic, we have a plethora of medications we can choose from insulin all the way to SGLT2 inhibitors. when would we consider this drug as our preferred medication in terms of the management of our patients? And for that, I'll use the current ADA guidelines. So the ADA guidelines say that our backbone for management of diabetes hasn't changed. It is lifestyle management. I think just a few days ago, Prof. York, our Vice President of GMA, spoke elegantly about lifestyle management of diabetes. Now, this hasn't changed, and we must continue using lifestyle as the backbone. But beyond lifestyle, if you have to start anybody on treatment for diabetes, what the current guidelines says is this: look for the presence of ASCVD or a high risk for ASCVD. If the person has any of these two, your preferred medication should be a GLP-1 receptor agonist or an SGLT2 inhibitor. So these are the medications we will choose in the presence of this or this. Now, beyond ASCVD, look for the presence of heart failure or CKD. And if the person has heart failure or CKD, these same two drugs are the ones we should use. But in that instance, preferentially, we should use an SGLT2 inhibitor over a GLP-1 receptor agonist when it comes to heart failure or CKD. These two drugs have made a lot of change. If you look at glycemic goal and weight management, they are playing major roles in terms of management of diabetes. Dulaglutide, semaglutide, tirzepatide, these are all GLP-1 receptor, and they have very high efficacy in terms of glycemic goal. And look at their effect in terms of weight management as well. Same semaglutide, tirzepatide. So they've changed the guidelines drastically, and we must find the evidence for why they've changed the guidelines, and that's the next part of our presentation. So why are we using this SH2 preferentially in the state of heart failure or CKD? And that's our next question. So for protecting the kidneys, there are three trials I want to just speak about briefly. The Credence trial, the DAPA-CKD trial, and then the EMPA kidney trial. These three trials recruited patients with significant albuminuria, 300, 200. Just didn't have any restriction when it came into albuminuria. And they progressively reduced the eGFR cutoff for the patients they studied. So 30, 25, and 20. They followed these patients up for a period of around 2.4 years averagely. What was important and striking was that all the three trials were stopped early on account of clear benefits of the agent use compared to placebo. Now, the three trials had different primary outcomes. However, the theme for all the for all the studies was this: will the use of an SGLT2 inhibitor reduce or slow down the decline in eGFR? Would it reduce death from renal or cardiovascular causes? All the three trials showed elegantly that this class of medications reduce death from renal or cardiovascular causes and decline in eGFR. And the relative risk reduction was averagely around 30%. And as I said, they were all stopped early on account of clear benefits of the agent used. The number needed to treat was also very low, 22, 19, 42, compared to other medications that you need to treat about 100 people, 120 people, before you get benefits. The renal protection that this class of medications offer doesn't start early. It starts from around 1 year of treatment. If you put your patient on this class of medication, you must tell them that the kidney benefits will not start early. You realize that the two trials, the curve separated at 8 months and then at 1 year. So by 2 years, they are really benefiting. If you have to put your patient on medication, they take the medication for 3 months, 6 months, and they stop. They will not get benefit with respect to protecting their kidneys when they are on SGLT2 inhibitors. And this is very major. Now, all the three trials showed beautifully that compared to placebo, this class of medication slows down the rate at which the eGFR comes down. So look at canagliflozin, dapagliflozin, and empagliflozin. In a couple of years that they were followed up, those who had placebo had a steeper decline in their kidney function compared to those who were offered SGLT2 inhibitors. And this is a very important finding that we must use to protect our patients who have diabetes and CKD. The other thing that this class of medication offers in terms of benefits is that they reduce albuminuria. So you realize that in the Credence trial, about 31% rate of reduction in albuminuria was seen compared to placebo. The rate of albuminuria was still very high for most of the patients, but those offered canagliflozin had a lower rate of albuminuria during that trial. Now, I just want to highlight something on this very important study, the EMPA kidney trial. So, if you look at patients with diabetes, they recruited patients with the highest population of non-diabetes. 54% of the patients who were recruited for the EMPA kidney trial did not have diabetes. Yet, they were able to show that both for patients who had diabetes and patients without diabetes, when you offer them this kind of medication, it protects against renal endpoints. Now, when it comes to EGFR cutoff as well, EMPA kidney had the least EGFR cutoff, yet they were able to show nicely that based, irrespective of the EGFR, when you put the patient on this class of medication, you have benefits. And the last thing the EMPA kidney trial also offered was that if the patient has albuminuria, very high levels of albuminuria, in the earlier trials of the Credence and the DAPA-CKD, they had clearly showed that these kind of patients who have very high albuminuria, they benefit from the use of this medication. So EMPA kidney tried something different. They recruited patients with no restriction in terms of albuminuria. And they showed beautifully that it is this section or the cluster of patients with high albuminuria that benefit from this class of medication. If the patients have normal albuminuria, they don't really benefit much with respect to renal protection, with respect to reducing albuminuria specifically. So now, besides using our typical diabetes drugs to protect the kidney, the 2025 ADA guidelines say that we have 4 different medications we can choose from to protect the kidneys. First is the ACE inhibitors, ARBs, which were released in 1981. We've been using this class of medication for many years. The second is the SGLT2 inhibitor, which I've showed the evidence for that they really protect the kidney. They reduce the decline in kidney function. They reduce albuminuria. The third is the GLP-1 receptor agonist, which the FLOW trial and other trials have shown that they also protect the kidney. And the last is the non-steroidal corticosteroid antagonist, finerenone. In the Fidelio DKD and the Figario DKD trials, they protect the kidney and they reduce cardiovascular events. So the ADA guidelines is now recommending that if somebody has diabetes and has kidney problem, let's think about these 4 drugs to initiate in terms of protecting the person's kidney. Beyond the kidneys, are there cardiovascular benefits of this class of medication? Yes, there are, and I'm sure we are all aware of this. So the first is with respect to heart failure. When it comes to heart failure with reduced ejection fraction, where your ejection fraction is less than 40%, there are 2 major trials that have showed benefit with respect to this cluster of patients. So the EMPEROR Reduced trial and the DAPA-HF trial. They had a composite outcome of cardiovascular death or hospitalization for Western heart failure. And what this trial showed was that there was, on average, around 25% relative risk reduction when it came to this composite of cardiovascular death and hospitalization for heart failure. You realize that as compared to the renal studies, the curves separated very early on. So for patients with heart failure, when you give them an SGLT2 inhibitor early on, you protect them from this composite of cardiovascular death and hospitalization for heart failure. And that is very major. For the heart failure patients, we must start the drugs early and let them know that they'll get the benefits early. For the renal patients, we must start the drugs early, but they have to wait for a long time before they get the benefits in terms of renal protection. Now, the other cluster of patients with heart failure with mildly reduced ejection fraction or preserved ejection fraction, where the ejection fraction is more than 40%. The other 2 trials that are major in that space is the EMPEROR Preserve trial and the DELIVER trial. Both trials also show that in this cluster of patients, there's on average around 20% reduction in the incidence of the composite of cardiovascular death and hospitalization for heart failure. And these are 2 major benefits that indeed was showed for these 2 trials. Now, earlier trials that were not heart failure specific trials also showed benefit with respect to the EMPA-REG, CANVAS, and DECLARE-TIMI trials, on average around 30% reduction in heart failure hospitalization for these patients. And that was also very major. Now, beyond protecting against heart failure hospitalization, this class of medication also reduced 3-point MACE. They reduce cardiovascular death and they reduce all-cause mortality. So this class of medications are now doing a lot when it comes to protecting our diabetic patients. And both the diabetic and the non-diabetic patients, we must consider this class of medication. Now, the EMPA-REG trial was the first trial to show these benefits. And beyond that, other trials were done to show the benefits. The CANVAS trial should show 3-point MACE reduction. Now, in the last section, which I want to talk about, because of purpose of time, I'll run a bit. In patients with both reduced ejection fraction and patients with preserved ejection fraction, this class of medications benefits our patients immensely. Now, the metabolic benefits of this class of medication. They offer weight loss, a very important aspect of this class of medications. They have durable blood glucose control, low risk of hypoglycemia, and they reduce HbA1c by between 0.5 to 1%. Very immense benefit when it comes to metabolic issues. And they have a lower hypoglycemia risk, as I mentioned earlier. Now, they also reduce blood pressure, very important. So this class of medication have about 7 different benefits beyond blood glucose control. They reduce systolic blood pressure by about 3 to 5 millimeters of mercury. Very, very important. in terms of the patients we see. So in conclusion, beyond blood glucose control, now we have a class of medication that can reduce blood pressure, body weight, offer cardiac protection, offer renal protection. They have a low hypoglycemia risk and they have 3-point MACE reduction. These are immense benefits of this class of medications beyond blood glucose control. And we must offer our patients this class of medications when they need them. If you look at the stages I mentioned about the CRM, stage 1 to stage 4, these two classes of medications have changed the game with respect to CRM. They can control stage 1 when you are obese. They can control when you have diabetes. They can control when you have subclinical CBD. And when you have full-blown CBD, they also are of benefit. These kinds of medications are doing more than herbal medications do for most of our patients. And you realize that they've changed the guidelines. Now for the guidelines, if you look at the algorithm, they feature very early on in most of the areas of the guidelines. The ADA guidelines have changed. The ESC guidelines have changed with respect to heart failure. The KDIGO guidelines have changed with respect to kidney guidelines. And we as doctors must also change. Up to 40% of our patients with diabetes may develop CKD. Diabetes carries a 2 to 4-fold increase rate of heart failure. We must select and give our patients appropriate therapy when they need them. We can start this class of medication at an eGFR of 20. And once we start, we can go all the way to renal replacement therapy. Let's remind ourselves that at an eGFR of 30, we can use metformin and some medications. We can use others all the way to eGFR of 1, insulin, linagliptin, and glyphosate. And my last slide, which is a very important slide, is Life's Essential 8. I'm not sure whether we all know about Life's Essential 8. It's by the American Heart Association. So this talks about the 8 metrics of an ideal cardiovascular health. What we should be doing to reduce cardiovascular diseases. So sleep, no smoking, regular physical exercise, all these are very important. And this class of medications, the 2 of them, offer these 3 in terms of the 8 metrics of ideal cardiovascular health. I think we do a lot of locum. We don't sleep. Doctors, we're always doing locum. It's one of the major reasons that can let us come down with cardiovascular disease. On that note, that's my last slide for this one. Thank you for your audience. So I'm moving on to the next one by Novartis. Then after that, I said I'm now from this small, so please pardon me. Get some water to drink before the Novartis. Let me grab some water. Our next presenter is now sitting in the plane. Okay, so I'm speaking on behalf of Novartis for the next section. And this one too is a very important topic that we must focus on. So optimizing ASCVD outcomes, the role of early combination therapy, LDL targets, and then adherence. So cardiovascular disease, as we know, are the #1 cause of death globally. They take about 17.9 million lives each year. And 4 out of 5 CV deaths are due to heart attacks and strokes. And a very significant number, more than 1/3, die prematurely before 70 years of age because of cardiovascular disease. Now, if you look at different regions, take the whole world, the #1 cause of death in 2021 was ischemic heart disease, followed by stroke as number 3. In the US, heart disease, stroke. In Ghana, stroke, ischemic heart disease. If you realize stroke and ischemic heart disease are killing everybody in almost every area of the world. We all will go, as we're sitting here, majority of us will go through stroke or ischemic heart disease one day. It's inevitable because that's the trend. But the question is, when will it come? Because we'll be going through this, but when will it come? I'm sure we will not go through malaria. We will not go through, but we are likely to go through one of these two. In Ghana, our average lifespan is around 66 years, whilst that of the US is around 76 years. So we are 10 years shorter in terms of lifespan. We must do a lot of things in Africa to increase our lifespan. And the major contributors to heart attacks and stroke include diabetes, our topic for today, dyslipidemia, our next topic that we are discussing, and then hypertension. We must reduce these risk factors to reduce the short lifespan that we have. Thankfully, dyslipidemia is a modifiable risk factor for cardiovascular disease. And in particular, LDL is that modifiable risk factor that we focus on. Up to more than 50% of patients with coronary heart disease are associated with dyslipidemia, and over 50 million patients in the world currently are on therapies for dyslipidemia. Now, current evidence shows that if you reduce your LDL by about 1 millimole per liter, you reduce the incidence of major vascular events by 22%. If you reduce it by 1 millimole, and this is the instance of using statins alone, if you use statins plus other medications, you reduce the incidence of major vascular events by 23%. So reducing your LDL by 1 millimole is a very important aspect of management of our patients. And we must encourage them when there's a 1 millimole and not discourage them that, oh, mami unya de kra, 1 millimole can do something in terms of the reduction. What we must pay attention to is that in the setting of primary prevention, when the person hasn't developed an ASCVD, the current recommendation by the guidelines is that we must maintain our LDLs very low. So from childhood type 1 diabetes, childhood obesity, all the other stages, when we are children, we must maintain around 2.1 millimole of LDL or less. If we do that, we only develop a 4% risk of getting a heart attack at 100 years. As I mentioned, we all go, but if you go at 100 years of heart attack, I think it's okay. Now, if you maintain your LDL levels of around 3.2 or higher, then you get the same 4% of getting a heart attack, but at 60 years. So the higher your LDL, the earlier you will get a heart attack. And that is what we must do in terms of preventing. We must start preaching lifestyle changes very early to prevent getting ASCVD. However, there's still hope. If you get one ASCVD, in the setting of secondary prevention, when you reduce your LDL to very low targets, it's been shown in the Odyssey trial, in the Fourier trial, that lowering your LDL will prevent another event from occurring. In secondary prevention, LDL must get very low targets. Now, there's a plethora of trials that have shown benefits in terms of primary and secondary prevention of coronary heart disease when we focus on LDL. So, what's the guideline approach to management of dyslipidemia? Who do we treat? What are the treatment targets? Now, LDL is our main treatment target by all the guidelines, but there are other secondary targets like ApoB, non-HDL cholesterol, and lipoprotein(a). Now, who do we treat? How do we go about it? The American Heart Association has given us a nice way to go about it. If you look at the lipid profile of any given patient, when the LDL is more than 4.9 or higher, the person qualifies for treatment, and that person needs a high-intensity statin. If the person has diabetes and is 40 to 75 years, he also qualifies for treatment. So all our diabetic patients we are seeing every day, if the person is more than 40 years, has diabetes, he qualifies for treatment. And if that is all he has, we should put him on moderate intensity statins. If he has diabetes plus other complications, then the other complications will determine the dose of the statins. Now, if you are 40 to 75 years and you don't have diabetes, the guidelines say that then use a 10-year risk ASCVD score. If it is high, put the person on statins. If it's intermediate, look for risk enhancers, the presence of CKD, family history of premature ASCVD. If you have them, put the patient on therapy. If you apply the 10-year risk score for a patient who is between 40 and 75 years and is very low risk, the person doesn't qualify for treatment. So we must know who we will treat for our patients. And the next thing that they say is that we shouldn't just treat our patients by putting them on, let's say, atorvastatin 20 or Crestor 20, and then we leave it there. We must risk stratify our patients into low, moderate, high, and very high risk. If you are low risk, your LDL target is 3 millimole. If you are moderate risk, 2.6, high risk, 1.8, and if you are very high risk of developing an ASCVD, your target LDL should be 1.4. And this must be our focus. In management of all our patients, we must look at whether they are achieving their LDL targets. And for patients who are categorized as being very high risk, these are patients who have developed an ASCVD. Say the person has an heart attack or a stroke. In that case, our target LDL is 1.4 millimole per liter. I'm going to nitty-gritty because of purpose of time. But look at the aspects of diabetes. We are focusing on diabetes in the last few days. So, if you have diabetes and you've had it for more than 10 years, you are at a high risk of developing ASCVD, and your target LDL must be 1.8 millimole. I'm sure we see a lot of patients with diabetes. They've had it for more than 10 years. We are not treating them to a target of 1.8 for their LDL. Now, if you have diabetes and you have had diabetes for less than 10 years, 2.6 is your target LDL. If you have diabetes and you have target organ damage, or at least 3 major risk factors, let's say hypertension, dyslipidemia, obesity, your target LDL is different. So really, there are a lot of things that we must know and we must put into practice in terms of the LDL targets for our patients. The previous slide that I showed was the earlier categorization that the guidelines gave: low, moderate, high, and very high risk. However, now they are pushing a new category. This is known as extreme risk. So now there are 5 categories we must place the patients in. And extreme risk patients, their target LDL must be 1.0. So these are patients with polyvascular arterial disease. We see a lot of patients. Somebody has coronary heart disease and also has peripheral heart disease. Our diabetic patients, they have a leg ulcer on one, they have heart disease on the other. Patients with polyvascular arterial disease, their target LDL must be 1.0. Patients with more than one ASCVD, somebody has 2 strokes or 1 MI, 1 stroke, their target LDL must be 1.0. And this 2025 ESC guidelines on dyslipidemia, they are trying to hammer on this a lot. The reason for this is that if we don't reduce the LDL, the persons may come down with a second event. And they are preaching that for now, we should start early combination therapy to reduce this risk. Now, if you have a stroke, within the next 100 days after getting the stroke, you stand a 10% risk of getting another stroke, another heart attack, another cardiovascular death. So having these conditions, you are at risk of getting another event in the next few years. You must be mindful of this and try and offer therapy at early stages. There are many trials that have shown the benefits of reducing the LDL targets to 1.4 and 1.0 and the benefits that accrue from that. Now, many years ago, in the last, let's say 10 years, the approach has been start statins. When it's not working, add ezetimibe. When it's not working, add PCSK9. And this is what we've been doing in a stepwise order. But from the 2025 focus guidelines by the ESC, they are saying that we should stop these guidelines. This is what they told us in 2019 that we should be doing. Now they are saying that they revised it. We should start early combination therapy to bring the risk of the persons dying in the next few months and years after one event down. So I do this to give us a very good idea of what it means to achieve our targets when it comes to LDL. Let's say somebody has a stroke and his LDL is 8.0 and you are seeing on your ward stroke patient with LDL of 8.0. If you put the person on a high intensity statin, let's say atorvastatin 80 milligram, you are going to reduce this LDL from 8 to 4 because it will offer you 50% reduction in terms of the LDL level. Okay, I think it's come back on. Now, if you were to use the high intensity statin plus ezetimibe, you get a 65% drop in the LDL, so you get 2.8. If you were to use a high intensity statin, ezetimibe, and PCSK9, you get an 85% drop in the LDL, and you get to 1.2. For a stroke patient, our target LDL is 1.4. So if you were to wait and to do high intensity statin today, in 6 months or 3 months, add ezetimibe, in another 3 months or 6 months, add PCSK9, the person would have gotten another event already. And that's the thinking that they are saying that now we should start early combination therapy to achieve our targets. If you know the magnitude of the patient's LDL, and this cannot only offer you that magnitude in terms of drop, start early therapy to offer the patient's benefits. There's a lot of unmet need when it comes to target LDLs for our patients. More than 50% of our patients on statins, after 6 months, they are not compliant on their medications. When would we consider PCSK9 in terms of management of our patients? Failure to meet LDL targets, or patients with very high LDL, whom from ab initio you know your targets for them, they cannot reach by just using one drug. Statin side effects, heterozygous familial hyperlipidemia. These are all patients we should consider in terms of using a PCSK9, for that matter, considering inclisiran. And for inclisiran, there are many trials that have shown the benefits in patients with established ASCVD, in patients with ASCVD or high risk for ASCVD, and in patients without ASCVD. There are many benefits in terms of inclisiran use, and we'll go through them in 2 minutes, and then we'll be done. So what's the evidence that inclisiran works? So in high-risk patients who have been on statins, maximally tolerated statins, yet they were not achieving their target LDL, these 3 trials, the Orion 9, Orion 10, and Orion 11 trials, have shown benefits. And so these are 3 trials that were covered, that covered patients with high risk, as I mentioned. and the patients were on statins. 90% of them were on statins, and over 70% of them were on high-intensity statins, yet they were not achieving their target LDL for their risk. Now, when they were recruited, they were given inclisiran at time 0, time 3 months, and then every 6 months during an 18-month period. Let's see what happened. So inclisiran was able to drop their LDL for all 3 trials, Orion 9, Orion 10, Orion 11. Look at placebo and look at inclisiran. It dropped the LDL levels significantly. And it dropped it by as much as 51% for the trials. Now, up to 74% of the patients who were in the Orion 10 and Orion 11 trials were able to achieve guideline recommended LDL of 1.8 for their risk. And so this is a drug that we can add to our patients when we have to achieve our guideline recommended targets. Besides our main target, which is LDL, where our main goal is always in terms of management of our patients, there are other secondary targets that I mentioned at the beginning, including lipoprotein little a. Now, this class of medication tackles all these 3 very importantly as well. When it comes to statins, statin targets LDL, ApoB, and non-HDL. But unfortunately, statins don't target lipoprotein little a. It is a PCSK9 that targets all 4 lipid endpoints. And so, in terms of this risk, which is a genetic problem that some people do have, we must think about this drug in that regard as well. But statins don't only control this, they also have pleiotropic benefits that we shouldn't forget and say, oh, now we are not giving statins still remain first line. Is that patients who require to achieve LDL targets early, we must consider combination therapy when they have very high LDL levels. And this is another important trial that was released this year, the Victoria Mono trial. In all the previous trials that they had done with PCSK9, it was on the background of statin therapy. This was a monotherapy where they used inclisiran in patients who had very low risk of developing ASCVD. They didn't have diabetes, they didn't have FH, and their 10-year risk score was very low. And so in this subset of patients who are almost healthy, not too bad, when they give them this class of medication, inclisiran, it was able to reduce their LDL by about 46.5%. So now we had evidence that in both monotherapy and in combination with statins, these drugs reduce LDL and by a higher quantum of reduction compared to ezetimibe monotherapy of around 11.2 and placebo that actually had an increment in those with the LDL. They were eating throughout the period and having high LDL during that trial. Now, this evidence from the Victoria Mono trial plus other trials have made a change in the FDA guidelines. This year, FDA has said that we can use inclisiran as monotherapy in terms of treatment of our patients. So it's no longer statin therapy. Now we are about ending safety profile of this class of medication. So the inclisiran has one major issue, injection site reactions, but that's not too bad. Erythema, pain, rash. Statins are very good first line, but they can cause muscle problems, myalgia, myopathy, rarely rhabdomyolysis. They can cause transaminitis. They can cause dysglycemia, and rarely they can also lead to proteinuria in terms of the kidney. In summary, what I want to say is that now there's a new class of medication that reduces both LDL and then our secondary targets. Has a durable effect. Once you start beyond the first year, it's only every 6 months that you give yourself. Very durable throughout the whole year. You need only twice yearly administration, and it enhances adherence because of that. Safe in renal disease up to end stage. So all the trials that they have done so far, they've not recruited patients with EGFR of less than 15, but above 15 it's been really safe. It's very tolerable, and they've used it in patients with ASCVD equivalents, and then heterozygous FH, and they've seen much benefits. My last slide is this one. Guidelines have changed this year, and they are advocating early combination therapy. We must treat our patients to targets, not just put them at statin or Crestor and leave it. We must look at the patient's risk category and then let them reach their LDL targets for their risk category. Every minute, somewhere in the world, 34 people die as a result of ASCVD. We must treat patients and reduce their risk for this. Diabetes is a major contributor. Obesity is a major contributor. Dyslipidemia is a major contributor to ASCVD. On that note, I thank you for your attention.
Thank you very much, Family Queen. FAMP or what? Dr. Family Queen. Thank you. Thank you very much. Yes. We're allowed to question. ASNA is very important. Just a little comment that your 2.6 target is for those who don't have any other risk factors. You should probably stress that. So diabetes without any other risk, but most of our patients are having hypertension and other things. So most of them will be 1 point. Thank you. Yes. Any, no, I hear it.
Sorry, I'm not sure if I missed it, but then those with the congenital dyslipidemia, most of them, the age for starting is above 18. So if you have a child with congenital dyslipidemia where they've been an MI in the family, so you want to start, which one is really recommended?
I'd like it if, can you put up my Novartis slide? I think it's a very good question. I just want a nice table to show the benefits. I skipped it because of time. Novartis. It's really good since we are discussing both adult and pediatric medicine. It's a good take home. Yeah, so this one. So you realize that I talked about 40 years and above because I was being a bit biased. Most of us see patients who are adults. But beyond this category where I ended, when you look at the age category of 20 to 39 and then 0 to 19 years, the guidelines provide for a few things. If you see any patients who is 20 to 39 years and the person has a family history of premature ASCVD and the LDL is persistently more than 4.1 treats, somebody is 21 years, no family history of ASCVD, his LDL today is 4.2. And you see him the first day, you are not obliged to put him on a statin or any medication. Now, if it's persistently more than 4.1 in the next 3 months, consider treatment, or if the person has a high risk. So 4.1 you see today, you can tell them to start lifestyle management, and this can go down. At the age of 20 to 39, your risk of MI and strokes is really, really low, and this is in that setting. Now, in the setting of 0 to 19, they really don't say that we should be putting our patients on statins, except if the person has familial hyperlipidemia. So if the person has FH, as for that one, between 0 and 19 years, we must put them on statins, and that is really major. I've seen 16-year-olds, 17-year-olds in schools being put on statins when they are within this bracket. There's no family history of premature ASCVD. They don't have xanthomas. So for those that we see with this age, between 0 to 19 years, we must apply a few things. There's the Simon Broom criteria. There are other criteria that we can use to make a diagnosis of familial hyperlipidemia. And one major thing is to look for xanthomas. If we see xanthomas in these patients with very high LDL levels, LDL more than 7.8 or 8 millimole per liter, consider this. Ask whether the father died before 55 years, whether the mother died before 60 years. That's a history of premature ASCVD. And not just dying, they died from an ASCVD like stroke or MI. In that category of patients that you are seeing with very high LDL levels, then you will treat. But for 13-year-olds, 16-year-olds who have enjoyed a lot of fast foods, and the LDL is just slightly higher, we shouldn't be putting them on medications. If they have FH, the guideline says that in that age group, we should treat. If you ignore treating these patients with FH, they will get a heart attack before 20 years. They will get stroke before 30 years. And it's a very important thing to catch the FH people in that group. Now, for those between 20 and 39 years, the LDL must be persistently more than 4.1. They must have a family history of premature ASCVD and other comorbid conditions for us to consider treatment. So let's remember two figures, 4.1 persistently for this, and 4.9 for anybody, especially for adults. We must treat. And for adults with LDL of more than 4.9, it must be a high intensity statin that we give them. Because at this level, the threshold of LDL can trigger ASCVD events. Thank you.
Thank you very much.
Thank you, Dr. Nikwe, for the presentation. I think still on the same tangent as Dr. Menu asked, because we follow different guidelines here. When you look at the UK 9 guidelines, they say offer statins to type 1 diabetes patients who have had diabetes for more than 10 years. And so assuming the child had diabetes at 2 and is 12, I don't know what we do here.
Okay, so that one, I'll leave the nitty-gritty to the pediatricians. But obviously, if you've had diabetes for more than 10 years, in my next table, you have a high risk of developing ASCVD. And that one, we must treat the patients to a target of 1.8. But because I'm not a pediatrician, I'll leave the pediatrician to make a categorical statement on having this. If you have type 1 diabetes, in the first 5 years, you don't get problems. So in the first 5 years, they say don't even screen for CKD. But after 5 years, you can get CKD, you can get retinopathy. So for the type 1 diabetic beyond 5 years, problems can ensue. And by 10 years, I'm sure each nation will have differences in terms of management. Now, most places have changed in terms of type 2 diabetes and the treatment. Canada still maintains metformin as number 1. Ghana will still maintain metformin, but other places, SGLT2 inhibitors and things. So it may be country specific. NICE guidelines may have their peculiarities, and our pediatricians in Ghana may have their peculiarities. But in general, having diabetes for more than 10 years, you are at high risk. And so I'm not surprised that the NICE guidelines says that after 10 years, put them on statins, because in that instance, you are standing at high risk of developing an ASCVD. Thank you.
Okay.
So we stratify them so that as part of the complication screen, they do the lipid profile. And then if there's a family history of sudden MI and all that, you are flagged. Okay, so start with the diet and all that. But I think from the NICE guideline, because usually the age of onset is around puberty. So when you say 10 years, then they are within the 20 to 30 group. So that's when they say treat. But you will treat if there's a family history. So you need to ask about family history of MI and all, and then we stratify them.
Thank you. I'm not a pediatrician, but just to add something small. So even with this one, they said young patients, type 1 diabetes less than 35 years, with a duration less than 10. So if you have a type 1 diabetic patient who is 18 years, and you are now seeing and he's 30 years, he's had the diabetes for more than 10 years. So you can give a statin. In that case, the minimum is to do the moderate. So that is also catered for here. My issue has to, okay, I'm taking both the SGLT2 and the statin. Yes, sure. In fact, this is a statement. Yes, to help us do the things earlier. One of the things I've noticed is that, yes, we love all these new drugs and all the things that they can do. Unfortunately, we normally start them quite late. And there is this quote here that I love so much. It says that the superior doctor prevents sickness. The mediocre doctor attends to impending sickness. And the inferior doctor treats actual sickness. So the import of it is that we should start the things early. So for instance, let me use my mom. My mom has diabetes. Yes, just to drive home a point. My mom has diabetes. She's 80 years. A1C is a target. She's on only metformin, but she has CKD. Okay, stage 2. So such a person, you should stop the metformin. Okay, even though she's at A1C, you should stop the metformin and replace it with an SGLT2 inhibitor. So those are some of the things that I want to say so that you can prevent the things earlier. Thank you.
Deputy Locum Doctor. Thank you very much. Please, any more? Okay. All right. Thank you very much.
Thank you very much.
Snack is ready. So, Madam Chair, please, do you have any last comments before we go for snack?
I think all comments will be at the end because we have to wait for the other presenters. Snack is for how, 15 minutes? 15 minutes. So please keep your questions, comments, and then we'll take them at the end. Luckily, by the time we finish, our next presenter should be in Accra. Thank you.
Very much. So just behind you, for those who weren't here yesterday, if you go through that door, snack is just to your right. Thank you. $15 minutes.
Like a father pities his child, so you love me. From everlasting to everlasting, your mercy I see. Oh, my soul, all that is within. Bless His holy name. Give me again. As far as the east from the west. Remove my shame. Bless the Lord, oh my soul. Bless His name. Oh. The Lord has established His throne on high. His kingdom rules over all forever. Glorify. Angels praise and pray, oh so great. Lord, my soul will bless Him every day. Bless His holy name. Give me again as far as oh, my shame. My soul. His holy name. Forever and ever. His love remains. Bless the Lord, oh my soul. Bless His name. Forever and ever. His love remains. I love you, oh Lord, my strength and song. You are my rock, my shield, my strong. Lord is my deliverer, my life. He saves me from the darkness. The waves of trouble rise around, but in your hands I am safe and sound. You are my rock, my fortress, my all. On your mighty wing, I will not fall. The earth may shake, the mountains roar, but your love sustains forever. He trains my hands for battle, my arms for war. His power lifts me also. Fortress, my all. On your mighty wing, I will not fall. The earth may shake, the mountains roar, but your love sustains forever.
Brenta is speaking online. She's been up since 1 a.m. waiting for us because of the time difference. Please. So our next presenter is Dr. Elizabeth Banker. She's going to do it online. She's out of the country. And actually, she's been up since 1 a.m. waiting for us, okay? So Dr. Banker is a senior specialist family physician, founder and head of Adolescent Care Clinic, Department of Family Medicine, Greater Accra Regional Hospital. She's the board chair of Diabetes Youth Care Ghana. Dr. Elizabeth Banker is a fellow in training at the Ghana College of Physicians and Surgeons and a member of the West African College of Physicians. With over 14 years of clinical experience, she's nationally and internationally recognized for pioneering adolescent medicine in Ghana and for founding the Adolescent Care Clinic, a multidisciplinary model for youth-responsive healthcare. She's the founding president of the Ghana Association of Adolescent Health and Medicine and chairs the board of Diabetes Youth Care, an NGO supporting young people with type 1 diabetes. Dr. Banker lectures in women and adolescent health at national training institutions and contributes to health policy through the Ghana Health Service and WHO Guideline Department Group. Her research focuses on adolescent non-communicable diseases, adolescent-friendly services, and transitions to healthy adulthood. Dr. Banker, you're welcome.
Thank you. Okay. Good morning, everyone. I'm in Montreal for the ISPAD conference, that's International Society of Adolescent and Pediatric Diabetes, and it is very cold. Anyway, let's go on. So I'm going to talk today about supporting children living with diabetes, the psychosocial aspects. And I hope that by the end of this session, we'll be able to describe the key psychosocial challenges in children and adolescents with diabetes, be able to identify developmental, family, and behavioral influences on well-being, and also to be able to apply practical evidence-based strategies to provide psychosocial support within routine care. I have to say, whenever we talk about children, I know we meant children and adolescents, but then they really like to make that distinction. So, because adolescents are not big children and they are not small adults. So, when we say children, it's a separate entity from adolescents. Okay. So, by way of introduction, we all know what the WHO definition of health is, and that it's a complex interaction between biology. So we're looking at genes, viruses, etc., psychology, which is mood, behavior, and then social factors, which is family and society. And to have a comprehensive definition of health, we will have to address each of these domains to be able to provide effective treatments. Okay. All right. So childhood is, some have defined childhood as ending at 8 years old. But then we know that WHO definition, when it comes to adolescence, it starts from 10. It's from 10 to 19. So when we are saying childhood in this situation, we are talking about from 0 to 19, or we could extend it to young people, which would include 24. So in childhood, young children can get stressed when they are navigating social worlds, particularly within their families, their schools, and also their friendships. And then when it comes to adolescence, we say that adolescence period is a period of stress and storm. We know there's a lot of major physical, hormonal, and psychological changes that occur within that period. And diabetes in childhood or adolescence can interfere with the normative developmental changes and interact with psychological and social factors for the adolescent or the child themselves, and then also for their families. So when we talk about psychosocial factors, what are we looking at? We're looking at the combined influence of psychology. So we're looking at mental and emotional. And then we're looking at social, so the environmental, the cultural, the relational, and then the economic. So these are the conditions that affect our individual behavior, our health, our well-being, and then the ability to cope with illness. So here, psychosocial factors are the emotional and social realities that shape a child or an adolescent's ability to live with and manage diabetes. So when it comes specifically to diabetes, psychosocial factors in diabetes, these are individuals with diabetes and their families are challenged with the multifaceted issues when integrating diabetes care in their daily life. And this is a complex environmental, social, behavioral, and emotional factors that influence persons living with diabetes. And in children and adolescents with chronic illness, such as diabetes, because we have other ones, the psychosocial factors that are influenced include how they think and feel, so about their conditions, their beliefs, their emotions, their self-image, and then how they behave in managing treatment. So we're talking about adherence and health habits, and then how their environment shapes their care, their family support, their schools, their peers, community, finances, and then culture. We know that chronic illnesses affects the mind, so as the person who has it, and then the family and society, and not just the body. So we are looking at the ecological, when we can refer to the ecological model of how chronic illness affects us. And the psychological issue, stresses that come about can impact the glycemic control, quality of life, and also adherence. And there's been evidence that psychological well-being is associated with lower HbA1cs and then reduced DKA admissions. I must say that one of the things that we've learned being here at the conference is when we have young people who have lived experience or who are living with diabetes, they talk about healthcare workers or healthcare providers focusing mainly on their HbA1c. And someone made a comment that, you want my HbA1c to be targeted. And that is your priority. And my priority is that I want my happiness to also be targeted. So this is something that we have to keep in mind as healthcare providers. So what is the response of the adolescent or the child to a diagnosis of diabetes? We have various domains. So looking at the emotional domain, this for both we see this in children and adolescents, and then I separated it for children and then with adolescents, because we know that they each have their unique characteristics, their unique sensibilities. So when it comes to emotional, both feel shock. There's denial, there's fear and anxiety, sadness, anger, embarrassment, diabetes distress, and there's mood changes. When it comes to children, there's separation anxiety because of it's traumatic for them. There could be emotional regression, and fear could be expressed through crying or self-blame. And then adolescents, they are afraid of stigma. They may be depressed, they may have identity distress, resentment, emotional suppression. Behavioral, there could be treatment resistance, irritability, withdrawal, declining adherence, need for assurance. So initially they come on board, we understand this is what we have, but after a while, it becomes tiring. And children may also respond by throwing tantrums, crying, being very clingy to their parents, and have a total reliance on caregivers. And for adolescents, it's skipping insulin, including for weight control. So that's one of the things they know, that if sugars are not controlled, I basically lose weight. So in that period where self-image is an issue, they find that, well, insulin could be a way. So that is a response that they could get. And then hiding care in public, risk-taking, it could go the other way around, that now they will take alcohol, they will smoke. There could be also a premature push for independence. Cognitively, they both may have misconceptions about the cause, worry about complications, poor concentration from stress or glucose fluctuations. And the children may have limited understanding of the chronic illness. And it could be that they blame themselves, or they think just about me, myself, and I. They are concrete thinkers. With adolescents, they may minimize the disease's severity because of the body image concern. They may have identity conflict, and then they can have a future-focused anxiety. And socially, there's a fear of being different. So avoiding self-care in public, possible isolation. I'm sure if we've worked with adolescents or young people or children, they're very concerned about going to school and other people see that they inject, because they may be, they may have different accusations. I've had young people come and say that, oh, they think I'm on drugs because I'm injecting. Okay. Children may seek acceptance from adults and teachers and may struggle to explain diabetes to their peers. And for adolescents, the peer pressure affects their care. So fear of rejection in friendships, romantic relationships, and then concealing the condition. I have young people, worried about, when do I tell my boyfriend or my girlfriend that I have diabetes? Or how do I even tell my friends, even if, you're not in relationships yet? And then within family relationships, there are needs of reassurance, emotional support, conflicts over care at times, and then boundary testing. A lot of parents end up being very overprotective because they don't understand, and also it's difficult to have your child being diagnosed with a chronic illness. The children, and then there could be clinginess, desire for parental presence, and then sibling jealousy. So my sister is not like this, I am like that, and every time when it comes to me, it has to be hospital. Okay. And then the parent-teen conflict over autonomy, resisting supervision, and feeling misunderstood. Already in the adolescent period, we have this. And so when there's a diagnosis, that makes things even worse. And when you come to the school, there's absenteeism, poor concentration, academic disruption, and then fear of hypoglycemia at school. Children are very reliant on their teachers and caregivers for support. And then the adolescents may avoid school care to prevent attention and then stress about fitting in. So you find out that they might even miss their doses, especially for those that are on the bolus and then the pre-meal. They may miss the pre-meal because they want to fit in, so they would probably eat without injecting or don't eat at all. And then with all of this happening, there could be a response that could be a positive response or an adaptive response. And so there could be development of resilience, learning coping skills, stronger caregiver connections, and then increased awareness. And the children may have comfort in their routines. They may trust the caregiver support. The adolescents will have increased self-management, peer support engagements, advocacy, health leadership. And then with the identity development impacts, they may have a sense of life disruption and altered routines. This you can see both in adolescents and children. And there could be disruption to sense of safety and dependence needs. And with adolescents, there's threats to autonomy, body image, social belonging, and self-identity. So their primary psychological theme is adjustment to chronic illness and emotional overwhelm. So the child will think of, am I safe and cared for? And then the adolescents will say, can I still belong and be independent? So what is the family's response to this, to disease or to diagnosis of diabetes? The typical family response, the emotional family response would be shock, disbelief, denial, fear, anxiety, guilt, grief, sadness, chronic stress. So you have parents coming and say that, how can I give my child this, especially when you talk about type 1 diabetes and we say that, oh, they are born with it. So they have that guilt. Why would I give this to my child? So, and they also worry about hypoglycemia, the complications. What's the child going to be? What's the future going to be like? I'm not going to be around forever. And then they may feel overwhelmed and they may feel inadequate. For the behavioral domain, there could be overprotectiveness. So there's constant monitoring, difficulty delegating care, rigidity in routines, and then there's caregiver burnout, and then occasional avoidance. So an example would be micromanaging insulin, glucose checks, diet, reluctance to leave the child with others. And this can be a real concern, especially when the young people are now, they reach primary, early, middle adolescence where they don't want mom and dad to be on them all the time. And that can be a sort of conflict. And their cognitive and then belief domain, there's confusion about diabetes care. There could be catastrophic thinking, misconceptions about cause or treatment, and then persistent worry. So they may think that, oh, one mistake could be fatal, and they have doubts about the ability to manage the disease. Then when it comes to family dynamics and relationships, there's increased conflict over care, strained marital and co-parenting relationships, unequal caregiving roles, sibling jealousy, reduced family activity. And we know in our culture, usually it will go something like, well, it's not in my family, so it's probably from your mother's family, because of course the man's family, they don't have that, or basically. And siblings may feel neglected. There could be so there's a need for coordination and communication increases. And then the social and community, there's fear of stigma or judgments and pressure from relatives, reduced social engagement, seeking community or religious support. We know that there are more doctors out in the community than went to medical school. So everybody has their take on what should be done. So families may withdraw socially or look for support groups. And financially and practically, there's stress about the cost of insulin, glucose monitoring, clinic visits, special diets, transportation challenges, and work disruption. We are fortunate that we have Life for a Child as one of the NGOs that provide insulin for free for us up to 25 years. And so that takes at least, gives a little bit of reprieve. And then the chronic disease burden can affect family finances and routines. So as has been mentioned before, what happens to that young person above 25 who doesn't qualify for free insulin, but then is economically not able to afford care? And families could also adapt and be positive. So there could be the advocacy for child's care, improved health literacy, structured routines, stronger bonds, participation with peer and then caregiver supports, which we're seeing that. I'll talk a little bit about that. And then over time, the families may often develop resilience, effective coping strategies. And then there's also the spiritual and unorthodox aspects of family. So they say that, oh, this could be witchcraft, this could be spiritual possession, and so then it can lead to relationships and then relationship strain and then rancor. So what must we do as healthcare providers? So we're at ISPAD, as I said before, and this is a picture of a young lady. She's Renata Valles. She's a songwriter and an artist in Mexico. She came in person, actually. I took this. And what she wanted us to know was, she's an advocate. She says, help us to know the system, not just the condition. And that we are fighting for the right to feel safe in our own bodies. And another one says, every number in your research is a person. So this is what they want us to know as healthcare providers. So why does psychosocial support matter? Emotional well-being impacts the glycemic control and adherence. And we look at guidelines from ISPAD 2024 and the American Diabetes Association from 2025. And they recognize that psychosocial care as a standard practice. We know that psychosocial distress leads to poor control, recurrent DKA, and then poor school performance. There are some developmental considerations that we should have for psychosocial needs vary by developmental stage. So for preschool, 0 to 5 years, the psychosocial features would be the dependence, parental anxiety, and then feeding struggles. And then how can we support, educate, reassure caregivers? And then school age 6 to 12, there's a desire for normalcy, inclusion, and the need for routine and autonomy. And what we do is to encourage inclusion and autonomy. Then when it comes to adolescents between 13 and 18, there's risk-taking, peer pressure, body image consent, and non-adherence. So as clinicians, we have to have shared responsibility, motivational dialogue. Transition to adolescent and adult care. This is very important for us, which is an area that is developing in our healthcare system right now. And it is very important that we start transition planning early. So by 12 to 14 years, we should have already started. And then we have to be able to assess readiness, teach self-advocacy, support emotional readiness and self-management competence, prevent dropouts during transfer to adult services, and then ensure continuity between pediatric and adult teams. So where I sit with adolescent clinic, basically, I am sort of within the space of, or adolescent care is within the space of transition, because we know that pediatrics, with their compassion, can hold on to children way into 16, 17, and then before they are transitioned to adults. But this is something that has to be intentional, and the correct preparation has to be made for that to be successful. So adherence and behavior. There are factors influencing adherence. So we know that age. Children, yes, when we can control it, and then when they are going to adolescence, they're developing some independence. So we know that definitely there are stages that within their age group that adherence could be a problem. And then also family support is important, their mental health, and then their school environment. With adolescents, rebellion, body image concerns, insulin omission for weight control. The interventions, as we've mentioned before, motivational interviewing is very important, positive reinforcement, and realistic goal setting. It's important that we avoid blame and focus on partnership and empowerment. A lot of the times, and this is the feedback we're also getting for young people living with diabetes, that it's all about my HbA1c. And you don't find out why it is what it is. And then also just feeling that when you see me as a person living with diabetes, all you see is the disease. You don't see me as a person. So that is something that also contributes to adherence and behavior. We have to be able to, for supporting resilience and self-efficacy, we need to encourage participation and decision-making. It shouldn't, we've gone beyond this paternalistic practice of medicine. If we want our young people and adolescents to be able to get better outcomes, we need to involve them in decision-making for their own healthcare. We need to praise effort, however little it is. So it's not just about your glucose results. I have young people coming and saying that my sugars are not being controlled no matter what I do. And then you talk to them and find out that, oh, it's, I'm having my period, and because of that, the sugars are not obeying anything. And that is reassuring for them that, I am doing everything that I can within my power, and it's not working. So I can either be encouraged that, oh, you know what, yes, you're going through this menstrual cycle, and after that it will be better, or you're going through a stress, or you're going to different things, and you encourage them, and that reduces their stress and helps with better glycemic control. We need to encourage problem solving, confidence, and then self-advocacy. We teach coping skills for hypoglycemia, illness, and then also peer pressure. We celebrate small successes to build mastery and motivation. So the school environment. School is central to psychosocial well-being, and the challenges that they face are stigma, not just from their friends, but also from teachers, from head teachers, principals. I've had I've had situations where school admission has been denied because they found out that the child has diabetes, or a child who is in boarding school, it's been found that the child has diabetes, or the adult has diabetes, and they're being told to become day students just because they have diabetes. And that could be quite traumatic for the emotional health of that patient or the young person. So stigma, and then lack of staff knowledge, and then fear of hypoglycemia. So we need to advocate for individualized diabetes care plan, whether with the school health nurse and also whoever, the house mistress or whoever is in charge, for them to know that this is what the young person might need. And then teacher and peer education. Then they have to have access to snacks, glucose monitoring, and then safe insulin use. I've had to write letters to for the young people when they're writing exams that they would need some time to take during the exams. They may need a snack, or they may need to have a break, or they may need to have something close by. So when they go into hypo, they have access to that. So you may have to write to the school or to the whoever is in charge that to make those concessions for that young person with diabetes. Then peer relationships and stigma. The fear of being different, secrecy, non-adherence, and then withdrawal. So peer rejection or bullying affects their self-esteem and control. So we need to encourage peer understanding, promote open identity and inclusion programs with support groups. So this is a camp from Diabetes Youth Care. That's a group I work with. So these are just pictures from that. And the camps have been incredible to help reduce isolation, to improve confidence in our warriors, or we call type 1 diabetic, young people living with type 1 diabetes warriors. Okay. So when it comes to mental health disorders, we know that depression is about 2 to 3 times higher in prevalence for children and adolescents with diabetes. And so anxiety has been linked to the fear of hypoglycemia and also being very perfect, because when you come in, they come in with their sugar profile, it has to be very perfect. So they have anxiety with that. And they could have disordered eating behaviors, so insulin omission, body image issues. We have young people who decide to just eat whatever they want to eat, and then once they check and the sugars are high, then they give more insulin to themselves. So we had we had some donations of CGMs and decided to just have some of the warriors try. And so, of course, it's set to the upper limit and the lower limit, whichever your levels are for hypo and hyperglycemia. And I thought, this would be it's a good experience for them to know, what they should eat and, what is too much or what is too little. And they found a way around it, in that when they're eating and then it beeps hyper, rather than stop eating, they'll just inject more insulin and continue eating. So in the end, we ended up with weight gain. So anyway, and it's important for us to do regular screening. So looking at the PHQ and then the GAD. So we're looking at anxiety for the PHQ and then the depression for GAD-7. And this is something that is recommended by ISPAD. As I said before, these are guidelines that we use quite frequently. And also the importance of integrating mental health professionals in diabetes clinics. Over at Adolescent Clinic, as part of our team, we have a clinical psychologist who's part of the team. And then when we do have our camps, DYC, I know they have clinical psychologists also available. So family dynamics, family cohesion and coping styles strongly predict outcomes better than the metabolic control. So there are positive factors when you have supportive communication in the family, that there's shared problem solving. So it's not just mother and warrior talking, but then when you have mother, father, everybody involved and supportive, they end up with better outcomes, better glycemic control. On the converse, you have negative factors such as conflict, inconsistent discipline, and parental guilt, also leading to poor outcomes. So we need to encourage family-centered care and joint participation in clinic visits. Shared problem solving is protective. When I have young people coming young people coming in, and they usually come by themselves, especially if you are less than 16, I encourage that you bring a parent. And it's been helpful because sometimes, you think that the parents may not care, but then sometimes it's because of their misconceptions. They are even afraid or anxious about their child's or their adolescent's condition. So they don't want to deal with it. They just avoid it. So it's very important for us to include them in the care. Parents go through stress. Okay. So the high parental stress is linked to poor child glycemic control. And then the common stressors could be the sleep disruption they may have, the financial burden, and the fear of hypoglycemia. Also caregiver burnout. So how do we cope? You provide emotional support and the link to counseling or peer networks. The support group that we have, I always keep referring to Diabetes Youth Care because that's what I'm involved in. We find out that even though we have the warriors coming and providing peer support, the parents also provide peer support for other parents, and it's been very good. It's really been something that it's our secret for success, I would say. And then it's important that we emphasize self-care for the parents. A supported parent supports better. Burnout with diabetes is very common, both for caregivers, I dare say for the medical healthcare provider also, and then also for the warrior or the person living with diabetes. There's emotional exhaustion from relentless self-management demands, and the signs could be apathy, missed checks, or disengagement. So we intervene by normalizing their emotions, sharing responsibility, and then peer mentoring. You can also schedule periodic psychosocial check-ins. The family-centered care is the strength-based care. So we need to shift focus from problems to strengths. This will help build resilience, adaptability, and routines. We need to recognize families doing well and reinforce positive behaviors. So there are structured diabetes programs that you can get on the net, Teen Star, etc. That helps to enhance coping and confidence in management. And then the social determinants and access. So, poverty, unstable insulin supply, transport costs add psychosocial stress. As we said before, we are lucky to have some, Life for a Child providing in major cities, really, but then those in the hinterlands who don't have, this is still a problem. And we also have to remember that children internalize family financial stress. So it's not, sometimes we just assume that, they are not, they are children. I mean, all they worry about is that their bellies are full and they have something to, close to wear, a place to sleep. But no, they do internalize stress. So that is something that we have to recognize and then intervene. So we need to advocate for equitable access and social support referrals. Communicating in clinical practice, we need to be empathetic, non-judgmental, and use non-judgmental language. That is something that also has come up quite frequently, where the language that we use as caregivers goes a long way to make or break the confidence of the caregiver, that's the parent, and the person living with diabetes. So if we are judgmental, we say things like, if you don't do it, this is going to happen to you and that is going to happen to you, and all of those things. It's difficult. And yes, if your sugar is not controlled, it would lead to kidney problems. We know that. But then there are other issues. It's not just about that. And that's why the young people are telling us that, you come and we come to you and you tell us all about the complications. You are not doing this, you get a kidney failure. You're not doing this, you go blind. You're not doing this, your wounds won't heal. You're not doing this. Sometimes it's very heavy. So they would like us to be a bit more empathetic. Ask questions like, how has this been for you? This opens, dialogue better, rather than, why didn't you do this? Why didn't you do that? And also involve both the child and the parent in your decision making. And then using motivational interview improves engagement and adherence. Patient-centered care. This is care that is respectful of and responsive to the individual patient's preferences, needs, and values, and ensuring that patient values guide all clinical decision making. So we have respect for patients' preferences. We give information and education, emotional support, physical comfort when is needed, access to care, involvement of family, continuity and transition, and then coordination and integration of care. The patient-centered care. So practicing personalized patient-centered psychosocial care requires that communication and interactions, problem identification, psychosocial screening, diagnostic evaluation, and intervention services. So this considers the context of the person with diabetes and their values and preferences. So practitioners should identify behavioral mental health providers who are knowledgeable about diabetes treatment and the psychosocial aspects of diabetes with whom they can form alliances. It's very important that we have coordinated care. And it goes the same way for diet therapy. We find that, especially the young ones, the children, They see dietitians or nutritionists who really don't know. I should say, yes, they know, but then may not be up to date, should I say, on nutrition or dietetic intervention. So there's so many restrictions on children. They grow up stunted, and they really shouldn't, because we have insulin and they need to grow. And sometimes some dietitians are not able to, let's say, give age appropriate and should I say diagnosis appropriate care or advice. So in the end, we end up with young people or children that are stunted and shouldn't be so. Ideally, psychosocial care providers should be embedded in diabetes care settings. So we need a multidisciplinary team. We've mentioned dietitians, we've mentioned psychology, physicians, nurse educator, social worker. And then there should be regular psychosocial reviews. So every 3 to 6 months, they should have a review. And then communication across team members prevent fragmented care. So if we're able to get a one-stop shop, as we have at Ridge, I should say, at the adolescent care clinic, for example, we have a one-stop shop where we can have continuous care, coordinated care, and comprehensive care. So integrating psychosocial care into practice. Psychosocial care is not optional. It is part of comprehensive diabetes care. So the strategies include the routine screening for distress, and then referral pathways to mental health professionals, and then peer group programs within the clinics. This is just a summary from the ISPAD 2022 about integrating psychosocial assessment in routine diabetes care. So we have to give age-appropriate and validated assessment tools, should be routinely implemented in clinical practice to monitor and discuss. So the overall psychosocial well-being and quality of life of all youth with diabetes. And this should also include the well-being of the caregivers. And then screening for symptoms of depression, diabetes, distress, and disordered eating in children aged 12 and above with using validated schools. So this should be done at the initial visit and then at periodic intervals, and when there's a change in disease, treatment, or a life circumstance. And psychosocial problems should be addressed upon identification. So if an intervention cannot be initiated during the visit when the problem is identified, a follow-up visit or referral to a mental health specialist should be scheduled during the visit. And then the cognitive capacity and school function should be monitored, especially in children with early onset, so age less than 7, as well as those who experience significant dysglycemia around the time of onset. This can be evidenced by the DKA, recurrent hypoglycemia, or severe hyperglycemia. So what is our take home? Psychosocial well-being is central to diabetes care. Support the child, family, and community. Empathy and multidisciplinary teamwork yield the best outcomes. Psychosocial health profoundly influences metabolic control and well-being. So as physicians, we must address emotional, family, and environmental factors. Integrate psychosocial screening and counseling into every clinic visit. And then to care for a child with diabetes is to care for a family, a school, and society. So, living with diabetes in childhood is not only a medical journey, but a deeply psychosocial one. Supporting that child or adolescent means supporting the entire ecosystem around us. So I just have to acknowledge Diabetes Youth Care over here. This is, we have support group meetings, camp meetings, school health, where the warriors or the people living with diabetes actually initiate going to their different schools to educate the school children about diabetes. And here is ISPAD, that's Dr. Vance, the founder, and then myself. So these are my references, and thank you. Any questions, please?
Thank you, Dr. Banker, for an instructive presentation. Yes, I am with you at Ridge. I've never been to your clinic. I should visit you.
Yes.
Okay, so we'll allow a few minutes for questions because she has to go to her conference.
Please, any questions? Mike will come to you. I'll ask a ravenous question for her. I'm not in her mind, but from yesterday, your abstract that you presented, I think it came out that the children who are in support groups, they tend to have diabetes distress more than those who weren't. I mean, from a study that she did. And so she was encouraging that we probably, the suggestion was probably from what they are seeing other people pass on, seeing other people getting sick and things like that. So I don't know how that ties in with the youth care, if you're seeing anything similar or whatever it is, and how you are supporting the children who are having these challenges. Thank you.
Okay. So thank you very much. Really, it's especially we saw that kind of distress, especially during the COVID time, where we were talking about COVID, who is at risk, which groups have a higher mortality, and I'll get calls like, Dr. Betty, my diabetes is one of the that's what makes me high risk for mortality. Am I going to die? And so then I had issue with how public health handled dissemination of or awareness to young people and children. But yes, you find out that there's that distress, especially when a warrior passes on or somebody who's close to them passes on. They have that, and a lot of the times, as I mentioned, if they don't, if we, the healthcare workers or the healthcare providers, are not very empathetic and we are very judgmental when they come in and they say that, okay, I've been doing everything I can, but my sugars won't budge. But then we don't listen to why or what their situation is, then they get distressed. Some people, they come and say, I'm tired. I have to inject myself every day. I am tired. And when I go to see the doctor, well, your HbA1c is not target, and you like doing this, and that's that judgmental sort of. And we're all guilty. I can say that I'm guilty of that too sometimes. That really contributes to the distress. So what I would say is that we should be very careful about our language. It's something that I think we should actually even invest in. Having a course or a program about how to talk to a child or an adolescent with chronic illness to make them improve their confidence and help with and result in a better outcome. So yes, it would really be around when one of the warriors has passed on or there's a complication. That's when you find that it's not easy for them. Yeah.
Thank you, Dr. Kutinsia, for asking my question for me. So this is a follow-up, Betty. This is something that I should have shared with you, but it came up after sub-analyzing my data. Then I realized that, and truly it was around COVID. The data was taken 2020, 2021. So it comes to confirm that during COVID, a lot of them were highly anxious of the disease. But one thing I realized also was with when you analyze the individual questions, them having an issue with the physician was really not a problem. Most of them answered for not a problem at all. But the main problem was the constant burden of living with the disease, how to manage the disease, and also the fear. So I think one of my recommendation was for us to, I mean, they hear about the warriors dying and everything, it affects them and everything, but to get a clinical psychologist really attached to the support groups and also for feedback session. I mean, I'm guilty of that. Sometimes when I pick something, I don't tell you about it, but then we all need to have this sort of a feedback session with the group leaders and also with their physician so that we'll be on the same page as to what we're talking to them about. Yeah, so that was one of the recommendations. But I agree, it was around the COVID period that most of them were under distress. And also to encourage that the physician should use the 7A model. I don't know whether you've been using the 7A model to assess their psychological distress. Okay, we'll talk about it.
Yeah, okay. So yes, I agree. And actually, I did a small study assessing service delivery at the adolescent care clinic, and it was a qualitative study. And I didn't do the interviews because of bias and all of that. And I was surprised what some of the warriors said, because they thought they were talking to a total stranger. And it was over the phone, so they really came out and to talk about what they really felt. And in the end, we had to advise ourselves as far as how we are interacting with them. They may not tell you, right in front of you that you make me feel this way or that way, but when they are given a chance, they really express themselves. So that is something that you have to have in mind. Okay,
Thank you, Dr. Banka.
thank you.
I don't think we have any more questions for you. Enjoy your conference
Thank
and
you.
keep warm.
Yes, thank you very much. Bye. Have a nice conference.
Our next presenter is here. Okay, we have to change the program a bit because she was delayed by her flight. Welcome. Okay, so our next presenter is Dr. Laila Matoga Educhum, MGCP PITS, Fellow European Society of Pediatric Endocrinology. She's the pediatric endocrinologist and senior specialist at the Maternal and Child Health Hospital, Kumasi, an adjunct lecturer, SMD, and at NUS. She's General Secretary for Ghana Society for Pediatric Endocrinology and Diabetes, which currently provides capacity building for healthcare professionals nationwide on management of diabetes in children and young adults, in collaboration with the Changing Diabetes in Children initiative. She has contributed to the development of the Ghana National Diabetes Guideline, and she's a member of Africa Society of Pediatric Endocrinology. Welcome, Laila.
Okay, good afternoon. I'm really excited to be a part of this conference and having come late and Umasi, I have to say Mema Mumuni, meaning that well done for holding the fort till now. Okay, so my time is limited, so I'll go straight on. Right. So this will be our outline for this session, and I'm going to delve into the pharmacological aspects of managing children and adolescents with diabetes. So look at insulin therapy in acute settings, insulin therapy in established diabetes, adjusting insulin, medical nutrition therapy, and then exercise in diabetes. I hope I'm not blocking. Okay. So insulin remains the mainstay of therapy in children and adolescents and also young adults who have diabetes, because most of them have type 1, right? And even for those who have type 2, they will be on insulin for some time before you put them on just oral hypoglycemics. So it's important that we know the inside out of insulin. Intensive insulin therapy, patient education, and support can reduce type 1 diabetes complications and improve long-term glycemic control. So the catch words are intensive. Okay, education does not end, it continues. Every day they come, you have to have a talk with them, giving them information about their condition and listening to them as well. It's complex using insulin. Okay, so if you are having difficulty, don't think that it's because you are not an endocrinologist. Even endocrinologists find it not too easy using insulin or trying to optimize glycemic control using insulin. Then insulin needs in children and adolescents are dynamic, and I guess you can understand why. Because they are growing, you have to change the doses accordingly. And then in adolescence, because of the hormones that kick in, you have to also adjust accordingly. And so it's not static. Then therapeutic lifestyle changes for children with diabetes focus on nutrition and physical activity, often with family involvement. I think we've heard a lot about family involvement already. We cannot overemphasize it. So we'll look at insulin therapy in acute clinical settings. Okay. So one of them is when you have a newly diagnosed or known case presenting in DKA. And then another situation is when a newly diagnosed or known case presents with just hyperglycemia. There are also instances where you have a child probably on steroids because of cancer treatment and comes with hyperglycemia and would need insulin for some time. So in the patient that is coming in with just hyperglycemia, so you have checked and there are no ketones in the urine, no ketones in the blood, right? So for such a patient, this is what you do. After your assessment and making the diagnosis of diabetes, of course, that is not what I want to do now. I don't have my time. So you've made a diagnosis, you have HbA1c, there are symptoms of diabetes, so you have established the diagnosis. So for such a patient, what you do is to give 0.1 unit per kilo 2 hours of soluble insulin till the blood glucose falls to less than 10 millimole per liter. If you have rapid acting insulin, you can go ahead and use rapid acting insulin. But soluble insulin is what is widely available. Then determine total daily insulin using a dose range of 0.5 to 1 unit per kilo per day as a starting point. So the first part usually will take about 24 hours to 48 hours. Mostly by 24 hours, the blood sugar has dropped and you can go on to put them on what they need on a daily basis. So when you have determined their dose, you will split using these guides. So between 50 and 70% of the total daily dose will be given to the patients as bolus insulin and 30 to 45% as daily basal insulin. What I commonly start with is 60% for bolus and then 40% for basal. Okay. So if I say 60% for bolus, what I mean is that before every meal, okay, there are 3 meals in a day, 3 main meals in a day in our setting. So before breakfast, the 60% you've determined of this amount. So if, for instance, the child weighs or the patient weighs, let's say 20 kilograms, and you start off with, okay, let me say here that a lot goes into determining the amount of insulin to start with. So if you are dealing with a pre-pubertal child, for instance, you will go in for 0.5, okay, because they don't have much of the growth hormone, sex hormones kicking in to counter the effect of insulin. So they don't have much of insulin resistance. So you can go lower. You can start off with 0.5. So a child is about 6, 5, 4, 7, you can start off with just 0.5. Then for those who are into puberty, 10, 11, 12, you can start off with 0.7. Okay, then the proper pubertal ones, the 18s, 20s, you can start off with 1. Okay, so if this hypothetical patient we are going to use, say, as a let's say pre-pubertal, 7 years, 20 kilograms, and I choose to use, say, 0.5 or 0.7. Let's use 0.5 times 20 is what, please? 10. Okay, so 10. So that means 0.5 times 20 is 10, right? So the child needs 10 units of insulin in the day. The total daily insulin for that child is 10. 60% of 10 is what? 6, right? So that is the amount that will be given during the day for meals. And for the 6, we'll split equally into 3. So 2 units for breakfast, 2 units for lunch, and then 2 units for supper. Exactly. Yes. Then the 40% that's left is how much? 4. And then we can choose to give all the 4 units as intermediate, as long-acting insulin at bedtime. Or if we are using intermediate acting insulin, say Insulata, NPH, whatever, we split it into 2 equal parts and give 2 in the morning upon waking up, and then 2 units at bedtime. Exactly. So that's how you start off. And I hope you understand how you decide on the dose to start off with, right? So once you've done that, then you put, this patient is still with you, she's not going home yet. Before that, you can only send this patient home when they've learned how to inject themselves and then how to check their own blood glucose and log into a logbook. Then they can go. And you've given the family education as well. Also on hypoglycemia and how to detect hypoglycemia and manage hypoglycemia. it is after all that has been done that this child can go home and come and see you again in a week to 2 weeks time. So the review period will be very short for such a case. All right. So we've talked about this. So the dietitian, they'll come to the ward and speak to the family about what the child should be eating, what they should avoid and all that. Then, so I've talked about refer, so let me move on. My time is limited. So now let's look at the situation where we have a newly diagnosed or known case presenting with DKA. Okay. So our patients who come in with DKA are not supposed to be managed on sliding scale. Okay. They need a different kind of approach to their care. So you've already determined that there is DKA by this criteria, isn't it? We check for ketones, the blood sugar is high, there's a history suggestive, and if you can do blood gases, you have done that, and there's acidosis. So the diagnosis is established. So the principle for managing DKA in our children and adolescents is to first try and correct shock if it's present, dehydration, hyperglycemia, deficits in electrolytes, and then the acidosis, and you treat the underlying problem and then complications if present. So this is what we usually don't get right in the emergency, most of our emergency rooms. And the reason I can say that is that mostly when we have transitioned patients to adult care, and as Dr. Banka said, the transition is not smooth at all. We haven't gotten there as a country yet. And so it's a rough time for them. When they go to the adult side, sometimes, depending on who is seeing them, they'll be put on not a so intensive form of therapy. So they are at risk of developing DKA. And when they come in with DKA, they are managed with sliding scale, and then they develop complications. We have lost a couple of our patients who we transitioned to adult care. And so when we have an opportunity like this, we try to highlight the problems. So we don't give a lot of fluids. You have to be guarded in giving IV fluids. So there's a quick phase. If there is shock, you will give fluids quickly. And we don't do boluses of 20 to 30. We restrict ourselves to just 10 mils per kilo of isotonic fluid because of the risk of cerebral edema. So note this. And then there's a slow phase where we correct fluid deficit and give maintenance requirements over 48 hours. So what you do is when you have resuscitated the child and you start giving maintenance IV fluids, you calculate what they need for 48 hours. And then you add whatever deficits. Most of the time, we advise that the deficit, if he's severely ill, up to about 10% of the body weight, use that as deficit. And then add it to the maintenance requirement and give it over 48 hours. So that will be slow enough to avoid complications. So when it comes to insulin therapy, you know that when you are treating or managing DKA, what you try to do is you set 2 IV lines, isn't it? You can't manage DKA with just 1 IV line. 2. So in one of the IV lines, you are administering your fluids, okay, with electrolytes, and in the other one, the insulin. Ideally, you should give insulin using an infusion pump. If you don't have an infusion pump in your facility, what you can go for is the word Dorsiflow. The Dorsiflow is now very widely available. Yes. And we want you to deliver insulin at this rate of 0.1 units per kilo per hour. And use half of this dose in very young children, toddlers. Use half of these doses. 5 years, 6-year-olds, use half. Then you aim for a glucose drop of about 5 millimole per liter per hour. and you do it slower if you are not able to monitor the blood sugar as often as you should, or potassium. You know, in our emergency, sometimes you go and they say there are no strips, isn't it? Or the patient can't buy the strips. So once the blood glucose is less than 50, you switch to a dextrose containing fluid. And what I typically use is the dextrose saline, DNS. And do not stop IV insulin until ketones have cleared. And this is an indication that metabolic derangement has what? Resolved. So the reason we are giving the insulin is not just because of the hyperglycemia, but more so because of the ketonemia. It is the ketosis that is causing the severe illness. So our intention is to get rid of ketones, and it's the insulin that will drive the ketones out. So you don't stop the fluid until ketones have cleared. And for that matter, you want to check urine ketones or blood ketones at least 4 times in a day. In fact, some even suggest every 4 hours. But I think in reality, for most of us, you can do twice daily. If you have the dipstick on the ward, then maybe you can do it as often as you can. Yeah. So the other caveat here is when the blood glucose is dropping. You see, sometimes we slow the rate of the insulin because there's hypoglycemia. That shouldn't be. What you do is to rather increase the dextrose flow rates, or make sure that the child is receiving the dextrose containing fluid, and that will deal with the hypoglycemia, so that there is no interference with managing the ketosis. Then also potassium is a very important electrolyte, and we must always add when we are giving maintenance IV food. So at presentation, the potassium may be normal, but then it will drop with treatment, because we know that in DKA, the potassium has come out of the cells into the extracellular space. So it may be low. And if the child presents with a low potassium, then it can become dangerously low during treatment, because during treatment, potassium will move back into the cells. During the treatment. Then when it's high, that is an indication that there's poor renal perfusion, and you should keep an eye on the urine output, so that when urine output improves, you can start your potassium. What you do is to add 20 millimole of KCl to each 500 ml bag of maintenance or resuscitation fluid. If the potassium is very low, then there is a need to start potassium early on in the management. So you add potassium to the resuscitation fluid, 10 millimole per liter in 500 ml bag of maintenance, of the resuscitating fluid. So usually DKA should resolve between 24 to 48 hours if everything is going on well. The patient should be out of DKA latest by 24 hours of commencing treatment. Okay. Then when you decide, so ketone, you check urine ketones. That's what we typically do. In my facility, I don't have blood ketone strips. We do reach for urine ketones. But the most sensitive is the blood ketones. Yes. When you have established that the child is out of DKA, then it's time for you to switch to the subcutaneous insulin, isn't it? We want the switch to overlap with the IV infusion. So, and preferably, you do that in the morning before breakfast. So there should be food, child is ready to eat. Then you give the subcut dose. And like we did for the first patient who came with only hyperglycemia, we calculate the requirements, just as we did for the one with hyperglycemia. We split the doses. And then we give the long-acting or intermediate dose we want to use. And then we give the soluble or rapid-acting insulin. And then wait for 30 minutes, okay, before we discontinue the IV so that the child can eat. All right. So it's the same thing like before. When we are treating children and adolescents with diabetes, we try to mimic what happens physiologically. Okay, the way things happen in the normal person. And we know that physiologically, the cells secrete a biphasic insulin to maintain glucose homeostasis. And we try to mimic that. As you can see, during meals, there's a surge in insulin secretion, isn't it? And then apart from these surges, there's a basal secretion as well. So the basal insulin that your body produces is what is responsible for keeping your blood glucose within normal in between meals during fasting periods. And then the bolus insulins or the surges that we see here are the insulin, are the ones that, keep the glucose spikes after meals under control. So the advice is to always select the guideline recommended insulin regimen. And what does the guideline recommend? It recommends intensive insulin therapy, given as multiple dose injections or through a pump, and the continuous pump system. So these are the recommendations. They are the gold standard for treating type 1 diabetes across all age groups. So pre-mixed insulin regimen using MPH and regular insulin in combination, the pre-mix, mix that, should not be considered as best treatment for type 1s. So if you have patients on pre-mix, please, you should try and migrate them onto the intensive insulin therapy. And it is nothing strange. It is just what we have described. Don't you agree with me? The calculating what they require and splitting using percentages, is it difficult? It's not. So that is what we are talking about. All young people should have rapid acting or regular insulin and basal, intermediate or long acting available and a means to inject this insulin. So if you have a patient who has diabetes and they are struggling to get their supplies, know that there are efforts to get these supplies to them free of charge. I don't know which facility you are in, but I'm very close to Confanoche, and I know that Confanoche supplies insulin to all their patients free of charge. And this is coming from the support of from Life for a Child. So it's free, they get strips free, insulin free, they just come with their NHI and health insurance cards, and then they access everything free of charge. So there's effort to get things free to them. So try and link your patients to the free care available. Then there is CDIC, and that is also doing same. Provide supplies free of charge. Very soon they are also bringing free insulin to their patients. So this table is just reminding us about the different types of insulin and how they work, their duration of action, onset, peak. So we have the common ones in our setting right now. Ultra rapid, no, I have not come across ultra rapid yet in Ghana, but there's rapid acting analog insulins around, and they work. Onset of action is very quick. Okay, about 15 minutes to 35 minutes. It's already doing its work. It will peak up to 3 hours, and then its duration of action is 3 to 5 hours. Then regular insulin is also common in our setting. That is what most of the free supplies will give you, regular insulin, not rapid acting. We are hoping that very soon they will get rapid acting. The funders or donors have brought out information that they are going to bring us. The next round of insulins that come will be for the bolus insulins will be rapid acting insulin because they have a better profile. Then, so these ones are for boluses. Okay, please let's get familiar with the different insulins here. So these ones are the boluses that we have, rapid acting and then regular. Then NPH or insulatard is intermediate acting. That one would work for 12 to 24 hours, but mostly, we know that its effect is maximal for only about 12 hours. And then it also peaks for 4 to 12 hours. And then also its onset of action is 2 to 4 hours. You should note the difference between the rapid acting insulin and the regular acting insulin, and also the difference between the intermediate acting insulin and the long acting analogs, so that you can appreciate why some are superior to others. Do you get it? So, for instance, when you compare the rapid acting insulin to the soluble insulin, the rapid acting insulin starts working very fast. So it gives the advantage of you not having to wait too long after you've injected it to eat. 15 minutes, you can start eating your food. But for soluble, you have to wait for about 30 minutes to start eating. Imagine if it's a child who is hungry and wants to eat. Okay. Then also, if you observe here, this one peaks for, rapid acting insulin peaks for 1 to 3 hours. But then soluble acting insulin will peak for 2 to 4 hours. So the relevance of this peaking is that the risk of hypoglycemia is high with soluble insulin because the peak stays in the system for a bit, a longer compared to rapid acting insulin. So that's why that one, the risk for hypoglycemia is less. And then the duration of action for soluble is also longer, also posing a problem as far as hypoglycemia is concerned. And you can imagine, please don't sleep, I beg. It's important that you get this. You can imagine combining NPH, okay? Please imagine combining NPH, okay? That peaks 4 to 12 hours, combining it with regular insulin, which stays in the system also for 5 to 8 hours. And I'll show you a graph and you appreciate what I'm saying better. This peaks, okay, as this is peaking, this one is about going down or its maximal effect is waning. And this peak and the time when this one's maximal effect is waning, when they coincide, what happens? Hypoglycemia. Okay, so that is why we prefer that our patients are on rapid acting insulins in combination with the NPH or the basal, because the basal long acting insulins, glargine, degludec, basagla, I hope you've heard about basagla. Yes, those ones, they don't have peaks, okay? They are basal. They behave like what I showed you in the previous graph. They are there. There's no peak. And so there's no there's not much risk of having hypoglycemias when your patient is on these ones. As we go on, we appreciate what I'm saying better. So here, this graph is showing us what happens if your patient is on mixed-start. Okay, so this patient has soluble insulin, intermediate acting insulin in one. And so when it's given, this is how the two insulins, this is how their profile looks like. So the yellow is the soluble, and then the red is the intermediate acting. You see, this is what I was talking about. This is what we don't like. because this will make them experience a lot of hypos. And this one at bedtime, in the night when we are sleeping, they could have bad hypoglycemias. Then have a look at this one too. Then you realize that this patient is on a long-acting insulin. You see that there's no peak using this one. And then as well as on a rapid-acting insulin. So it doesn't stay so long in the system to pose any risk of hypoglycemia. So this has a better profile as far as managing the glucose in the bloodstream is concerned. This one looks a bit bizarre, but you appreciate it if you are alert and you study it. So please open your eyes and see what is happening here. Yes. So you see that the purple line over here is basal, is long-acting insulin. Okay. The purple is Lantus or Levime. That is it. No peaking. So if you combine it with a rapid-acting insulin, this is the effect you get. Then this one is soluble insulin in combination with so whichever you are combining with, if it's MPH together with sorry, I'm confused, forgive me. MPH is the green one here, you see. So if you are combining this MPH together with this soluble insulin, okay, this is what we are worried about. But if you are combining MPH together with rapid acting insulin, you see, rapid acting insulin, when it peaks, it has no broad peak compared to this peak. This peak is broader. Do you realize that? So rapid acting, the peak is narrow. So the risk of hypo is lower. And then when you combine it with the long acting too, there's no, what do you call it, meeting of this one's peak with this one. So the hypoglycemia effect is also negligible. Okay. And you have to let your patients know what the target is. When you put them on insulin, they should appreciate what we are trying to achieve. So you let them know this is the blood glucose range that we prefer you to be in most of the time. This is your HbA1c target, should be less than 7%. And for those who are on the pump and using the continuous monitoring system, their apps will also give them this as a target. So if they are on the continuous monitoring gadgets, it will tell them times in which they are in range. And the ideal is that for 70% of the day, you should be in range. And being in range means that your blood glucose is between 3.9 to 10. Okay. So out time above range, it will show you it's in the yellow. Okay. And then the red, you are below range. Hypoglycemia. Yes. So these are situations where you are having hypers. So as our patients mature, we try to help them to attain tighter controls. So this 4 to 10 is not for every patient. So for fasting blood sugar, if you are a teenager or a young adult, we advise you and help you to look at a fasting of less than 7. Okay. Then 2 hours after meals, your blood sugar ideally should not be more than 10. Then before meals, we advise that it's less than 8. Okay. So the older the patient, the tighter their what do you call it? The tighter the expectation. If it's a toddler, a child, we tell the parents that our target is 10. Fasting crying 10. Do you get it? So that they don't get hypos. Then blood glucose monitoring. This is what you give them. These days, I think the donations come with diaries as well. So your patients may benefit from diaries straight from the clinic. Otherwise, before they go home, they go and buy a notebook. And in the notebook, you rule the lines for them. The dates, blood glucose before breakfast, the kind of breakfast you took 2 hours after breakfast, blood glucose before lunch. Then the lunch you took 2 hours after your lunch you test. So if I say 2 hours after the meal, it means 2 hours from when you started eating the food. Not 2 hours from when you finished eating the food. 2 hours from when you started. Because you know some people, they are on the phone when they are eating. And they use about an hour to finish eating. So 2 hours from when you started eating the food. So that is what, so they have to check so many times in the day. The many tests are necessary so that it can help you, the healthcare professional, to understand how their blood sugars are, so that it will help you adjust their insulins accordingly and advise them and educate them. So if you have a patient who comes without a diary, the patient is not helping him or herself, and you too, you are not helping the patient. You have to require it. In my clinic, if you come without a diary, I tell you, we cannot see you today. Because all the conversations we are going to have will be based on what is in the book. Okay, so they have to have a diary. And apart from these tests, they may be required to test. Bedtime is mandatory. It didn't come, it's not included here, but please, bedtime test is mandatory. And then sometimes at 3 a.m., 12 midnight and 3 a.m., they have to test. Why? Because if you are having abnormal sugars in the morning, pay attention, please. If you are having, say, hypoglycemias in the morning, or let's say hyperglycemias in the morning, you cannot just go and increase the pre-dinner insulin or bedtime insulin because the blood sugars in the morning are high. Because if you do that, you could kill the patient. For all you know, there's what we call the Somogi effect, isn't it? You remember? The Somogi effect is when the blood sugar has dropped so low in the middle of the night that when counter-regulatory hormones kick in, then it rises so that you see a hyperglycemia in the morning. So if you give such a patient additional insulin, you will kill the patient. So when you see abnormal sugars in the morning, always let them check for you 12 midnight and 3 a.m. It's difficult to get up and do those tests, so we don't tell anyone to do that throughout the week. What we advise is weekends, when you are not going to wake up early to go to school or go to work, Friday dawn, Saturday dawn, and then Sunday dawn. Right, yes, we can do these tests. And then we see for 2 consecutive weeks and we can take a decision. And for the teenagers, sometimes it's as a result of what we call the dawn phenomenon, because they have, high surges of growth hormone when they are sleeping, okay? And then also the sex hormones, testosterone, these can bring the blood sugars up. So because they are counter-regulatory to insulin. So the sugars will be high at dawn, and that is the high you are seeing in the morning. So if they test for you 12 midnight and 3 a.m. and you see this, you know that you can increase the insulin at bedtime and also pre-dinner. There are individual insulin dose variations, no two ways about that. Daily insulin dosage varies greatly between individuals and changes over time. During puberty, requirements may rise substantially, above 1 and even up to 2. So you have to understand this and then increase as necessary. It therefore requires regular review and reassessment. That is why our patients, they cannot go for long, periods without coming for review. You have to see them frequently. You can only allow them to go for long periods if they really will not be around. And even that, you have to give them your number, so that they can contact you, so you have a conversation about what is happening with their blood sugars. The distribution of insulin dose across the day shows great individual variation as well. Okay, so I have some patients who you cannot even say that everybody must have a bedtime long-acting insulin. No. So for some, at a point you might have to remove or give that bedtime you started with dose to the morning because of how the blood sugars are behaving. And maybe you started by giving the hypothetical case you said 2 for meals. You realize as time goes on, for some you may give the more of the pre-meal insulins at certain times and reduce that for other times. So you may have a patient who is getting, because let's say the patient comes, you look at the blood sugars. There's a typical one I remember I can use. So this one had every 2 hours after breakfast check was hypo most of the time. And this child is in a, what do you call it, a home, orphanage. So you cannot control how much you get to eat or something. So because the 2 hours after breakfast tests were low most of the time, I realized that I have to reduce the insulin for the breakfast. So I reduced it and then let them go home. 2 weeks they came. When he came, he still had some hypers. Because I knew about the post-breakfast hypos, I didn't dare increase the pre-breakfast insulin. So whatever additional insulin I wanted to add, I avoided that part and added it onto the others using the the diary as a guide. Is it clear? So your patients, they may be on different doses at different times. It is not straight jacket that if you are receiving 2 units for breakfast, it should be 2 units for lunch, 2 units for dinner. No. And then the same goes for the basal one as well. The most important thing is for them to be on the right dose for their weights. Do you get it? But sometimes you see children and patients, and the insulin doses they are on so small, it's like it's not controlling anything. Use the weight to calculate their requirements. Okay, so let's go on. So there are situations that necessitate insulin adjustments, and usually soon after diagnosis. When they come, that is when you are going to appreciate how their body is, reacting to the insulin. So you can adjust according to that. So you titrate. So immediately after diagnosis, when you send them home, that's why I said 2 weeks maximum, they come for review. And it will be necessary for you to do some adjustments based on what the diary shows. Then during the honeymoon phase, for some 3 to 6 months after diagnosis, their insulin requirements will go so low and they will be getting recurrent hypos. In such situations, you have to reduce the insulin. That's when they will tell you that, I told you that God will help me. Now my child doesn't have the disease. So it's honeymoon. So you reduce the insulin doses accordingly. Then in well-established, and in honeymoon, we go to about 0.5 or less per kilo per day. Okay. Then you continue monitoring, because sometimes a few months later, you are having to increase the insulin again. Then also variations in lifestyle routines, especially exercise or dietary changes, travel, fasting, sick days. Some people, not some people, when you are sick, you may have to adjust your insulin, because some sicknesses will raise the requirement and some will reduce the requirement. If you are vomiting and not able to retain anything, there might be the need to do what? Reduce the insulin. And then fasting. Our young adults, when it's time for them to do their fasting, it doesn't matter what you have used to scare them about diabetes. They will go on their fast. So please let them know that if they have to fast, they should tell you, so that you help them manage their diabetes, because fasting doesn't mean you should be off insulin. Because as you know, we started off by saying that in between meals, your body is still making what? Glucose. So you need insulin to control those surges as well. You should also know about the insulin sensitivity factor. Okay, and it tells how many points in millimole per liter the blood glucose will drop for each unit of insulin. and you calculate this for your patients. Every patient has their own insulin sensitivity factor. And this is the formula, 100 divided by the total daily insulin. So if this patient's total daily insulin is 30 units, the insulin sensitivity factor is what? 3.3. We don't give insulin in fractions, so we will not round it off to 3. So the insulin sensitivity factor is 1:3. That means 1 unit of insulin will reduce the blood sugar by 3 millimole per liter for this patient. Okay. I hope these slides will be given out. Yes. So you subtract the blood glucose, the target blood glucose from current blood glucose. So if your target is that at this time the patient's blood sugar should have been 10 millimole per liter and they are 15, you do the subtraction and the difference is what? 5. Then you divide the difference by the insulin sensitivity factor, which is the 3 we got here, and you have 1.6. You round that off towards 2. So what happens in this case is that the 2 units will be added to whatever the patient was going to give for the meal was about to take. So if for the pre-meal she was going to inject 5 units, 2 should be added to deal with the hyperglycemia that the patient has at that time. But then if postprandial hyperglycemia persists after correction insulin dosing, the insulin sensitivity factor should be reviewed. So if you have a patient, you've worked out the insulin sensitivity factor for him, but whenever he comes, he still has highs in spite of using that correction dose, then it means you have to review the patient's dose altogether and find the new insulin sensitivity factor. So for some of your patients, you may be able to let them work it out like in the previous slide. But for those who cannot, children, mothers, please, you have to create this table for them using the formula we just looked at. So you let them know that whenever the blood glucose is between 12 and 13, for that patient, the same insulin sensitivity factor, I drew this table for that same patient. So if they have this, it's easy. So they are able to manage hypers at home. So when you have to adjust insulin, what you do is to think around the blood glucose results before instituting any change. You watch the levels for 3 days to 1 week. So don't react to individual blood glucose tests. So, I've checked my blood glucose is 30. Okay, in that case, add 5 to your pre-meal. What you do is to check what is happening for over a period so that you understand the trend so that you can properly intervene. Okay. I'll finish soon. And then you want to address hypoglycemia first. If your patient is coming with lots of hypos, the diary shows that he's been having hypos, we are very worried because this patient can, have a very bad event. And when they have a bad event, a symptomatic hypoglycemia that causes seizures, loss of consciousness, sometimes they will not adhere to the insulin again. So you look at hypo, and the other problem with hypo is if you keep getting hypos, you go into what we call hypoglycemia unawareness. Time will come when you have hypo, the body will not give you any signal. And so that is dangerous. So address hypo. If they are having hypos and even if they are hypers, please address the hypo. Ask them, what do you think is caused? Sometimes they will tell you their story. One guy said, and I'm in a shop, and when people are coming to buy, I've already taken the insulin, and they are buying. I can't let them go. I have to finish serving them before I sit and eat my food. So we said, then whoever employed you, does he know you have diabetes? He says yes. Then he has to find someone to help you in the shop. So that's what we are working on. So always try and understand what is causing the hypo so that you can advise. Then when you have to adjust, sometimes when they come, all the sugars everywhere are high. then you have to increase the total daily dose, and you can do so by mostly what I do is to add about 10 to 15% of the total daily dose. So for whatever you are on, I'll calculate 10% of it and then distribute the various doses. And then I review you shortly after that. In type 2, you know, the adolescents with lifestyles these days, they come in obesity. Those with a family history, they come in with type 2 diabetes. If everything is pointing to type 2, what we do is to determine if the HbA1c is greater than 8.5. If it is high and you are symptomatic, you'll be started on insulin. Preferably, you should be started on basal insulin. But more often than not, we are having to give them, what do you call it, MDI. Put them on MDI as well. Then gradually, we migrate them onto metformin. Then also in type 1, when there is obesity and insulin resistance, when the insulin requirements are rising to 3 units per kilo per day, 4, we add metformin to improve the, what do you call it, sensitivity to insulin. Medical nutrition therapy. So I'll summarize, don't worry. So what my time is up. But you appreciate that this one, I can't do it in a rush, isn't it? When I was coming, I was asking myself, well, how can I do insulin in? So we want to turn away from the old way of doing things. That is what medical nutrition therapy is about. So we don't say that because you have diabetes, don't eat this, don't eat that. That is what used to be the case centuries ago, because there was no insulin and they had to restrict their diets. But with insulin now available, what we advise is for them to eat what is culturally acceptable, what they are used to in their setting, and then have enough insulin to cater for the meals they've taken. Do you get it? So that they are not disadvantaged in any way. And for our children, they need to grow. So if you restrict food and all that, their growth will also be affected. So our emphasis is for them to eat our local foods, the complex carbs with fiber, okay, and then protein and all balanced diets. It's important that they learn to eat at specific times. You see, eating snacks is not by force, or we are not supposed to encourage our children. It's as if we are in a setting these days where snack eating is like, it's normal. But what is the right thing to do is to eat your food at specific times. So breakfast, you eat all that you need to eat. Lunch, you eat. In between, ideally, avoid eating. Unless, of course, you have hypos. Even if you have hypos, you should try and understand the basis of the hypos and deal with it. And don't encourage grazing the in-between foods. Yeah. So there's no such thing as a diabetic diet. And exercise is also very important these days because of obesity. Our children are becoming resistant to the insulin. And so we advise that they do moderate to high intensity exercises. Encourage them to do chores at home. Chores are also part of exercises. These days, in reality, it's difficult to get children to go out and play. Let's face it. So at home, you discourage them sitting to use the screens, but advise them to do chores, sweep, wash the dishes and all that, mop, scrub. All these are helpful. The benefits are enormous. I'm sure we all know the benefits, including improved insulin sensitivity. And there are barriers to exercise that we should all know. Because when they come and we keep saying, munya exercise, there are barriers. Maybe they've done exercise and there was hypoglycemia that almost killed the child. You have to address it. And then also, when they have to plan for the exercise, get snacks and all that, it makes them laid back when they have to go and exercise. Then there are precautionary measures to adhere to. You have to check the blood glucose before and frequently during after exercise, because the risk of hypoglycemia can last for about 24 hours after you have done moderate to high intensity exercise. So after the exercise, there might be the need to reduce the insulin that you take for your meals and even at bedtime because of the risk of hypoglycemia. Then when you have ketones, you don't exercise. When there are complications too, you don't exercise. I'm done. Thank you very much for your attention. All right, finally.
Thank you, Dr. Edichum. Questions will be after.
Okay.
So we have one more presentation by Sipla.
A very good afternoon to you all. All protocols observed. I'm Ivan Samwakwata. I'm a pharmacist. I'm a member of the CIPLA team Ghana. At CIPLA, we believe, and actually our ethos is caring for life. So everything we do is geared towards ensuring that life is being cared for. This year is particularly a special one for us at CIPLA because it marks 90 years of caring for life. So for 9 decades, we've been providing quality but yet affordable medications for patients across the globe. And Ghana is, in fact, a typical example for what we do for our patients. I mean, beyond just medications, we are into some other corporate social responsibilities, but I'm told I have only 10 minutes to I'll be snappy. I mean, as CIPLA, we will make a difference, and the difference is beyond the pill. We are not only interested in selling medications, but making sure that patients are very well taken care of. I mean, today's presentation is going to be very brief, and it's just going to highlight what we have in our cardiovascular and diabetes portfolio for patients. And the very first one we have is Centrexa, which is our brand of dapagliflozin, 10 milligram, which is a cardiorenal protector. So this Centrexa and it's mainly dapagliflozin 10 milligram for our patients. I mean, when you look at the ADA guideline for our patients with diabetes, diabetes with heart failure, diabetes with CKD, CVD, and also more importantly, our patients who have diabetes but at very high risks of cardiovascular complications. So if you look at the ADA guideline, they are typically patients who are diabetic, who are 55 years and above, patients who are dyslipidemic, overweight, and tend to have any two of these complications together with their diabetes. So we have Centrexa for them. Also, if you're only looking at managing HbA1c and glycemic control and weight management goals for this patient, the guideline recommends SGLT2s for this patient. And you realize this is evidenced by the DAPA-CKD trial, DAPA-HF, DECLARE-TB, and the DELIVER trials. So that's Centrexa for you. Now, CIPLA is a branded generic company, so we are actually bringing alternatives to medications that are actually on the market. Our bedrock and hallmark for whatever we do is quality. So we ensure that for every medication we bring onto the market, which is an alternative of the innovator, we ensure we have bioequivalent studies that will guarantee that the medications you give to your patients from CIPLA are going to give the patients the same effects as though they are taking the innovator. There's actually 2 independent bioequivalent studies that were done on Centrexa against the innovator. So you see the graph, the innovator against Centrexa, and there's a beautiful overlay of the 2 graphs that shows that Centrexa is bioequivalent to the innovator. That's to say that Centrexa is a very cost-effective alternative for your patients, and hence, when you put your patients on Centrexa 10 milligram, you're not shortchanging them, but actually you are saving them a lot of money. You're improving compliance for them. Now, as part of our cardiovascular portfolio, We just introduced a branded generic for rivaroxaban by name Tariva. So we have Tariva 2.5 milligrams, 10 milligrams, 15, and then 20 milligrams. Typically for our patients, we want to prevent DVT for them if they've undergone total hip or knee replacement surgeries for the 10 milligram, and that's evidenced by the records trials. 15 and 20 milligram for management of DVT and PE for our patients, and this actually the Einstein DVT, Einstein PE, and Einstein extension trials. Like I mentioned, quality is a hallmark for us, and we want to make sure that the patients are getting the utmost best from the medication. So this actually also a bioequivalence study that was done on Tariva against the innovator. I mean, the bioequivalence study sought to look at the maximum concentration in plasma against absorption, and more importantly, also the safety profile for the patient. I mean, it was a randomized open label 2-period sequence trials that was done. That's to say that the patients who were on Tariva were, after a 7-day washout period, were also placed on the innovator, and vice versa. This to make sure that the patient who was on Tariva happens to be the control for that same patient. I mean, the safety endpoints, we had only 3 adverse reports, adverse events reported, one for Tariva and 2 for the reference. And it's important to note that these reports were not related to the medication, but actually to the patient. I mean, in conclusion, Tariva showed and proved to be bioequivalent to the innovator, and hence the patient is going to get the same benefits they get from the medication as though they are on the innovator medication. There's also a beautiful value of the 2 graphs of the reference medication against Tariva, and it showed that it's bioequivalent. Like I mentioned, the indications for Tariva mainly for patients where we are looking at preventing DVT and PE for them after they've undergone total hip and knee replacement surgeries. That's for the 10 milligram once daily, and also for our patients who are coming with DVT and PE. We are looking for management. I mean, the guidelines recommend 15 milligram BD for 21 days, followed by 20 milligram once daily, based on the patient's breast profile, either indefinitely or for a period of time. So basically, that's what we have for Tariva. This is a very cost-effective alternative, and we say the patient is getting reliable protection for less than 12 cedis per day. When you just oppose that to the innovator, you realize that this is a more cost-effective alternative on the market for the patient, and more importantly, going to improve compliance for them. I'd like to say a very big thank you for the opportunity to present to you this interest. Thanks so much.
Thank you. We've been sitting for a while, but I must say that question, we should do our questions. Okay. So they don't have to sit there. Oh, it's okay. All right. If you have any questions for the presenters, please. She's going back. She's going back. You are oversaturated or hypoglycemic.
So can our panelists kindly be here for the Q&A session? Yeah. Dr. Mino. Okay, so any questions for Dr. Minu and then Dr. Leila in the show?
Thank you. Thank you all for the very insightful discussions. I think mine is more of a contribution to Dr. Aduchu's presentation. It was just in reference to the general presentation yesterday. As we also, the insulin thing is quite complicated and all that. So there's an app called Diabetes M app that you can actually put in the patient's details, put in like their individual characteristics, and you can do all these calculations for you without having to, do it at every point. So I think that over time, as we try to incorporate tech and all that into our practice, that might help make our lives easier and also easier for the patients. Diabetes M. Yeah, so we can put in all the details and then do the calculations for you.
Thank you very much. My questions are for Dr. Educho. The first one is has to do with insulin. You know, when we say, oh, the insulin is too much or it's too little, it has to do with reference to the quantity of food. Okay. And therefore, I expected that our dietitians would help us with carbohydrate counting. I never hear anything about it most of the time. And so it becomes quite a challenge. Yes, I know you need to be highly literate and numerate to be able to appreciate and do some of this. But there are still some people who can do these things. So where does that fit in? Because we hardly talk about carbohydrate counting and all that. And then my last question is, this issue of adding metformin to insulin for type 1 diabetes patients, is it something that is standard or we have adopted it? Because I've heard a lot of debate about it in the sense that in type 1 diabetes, we are not talking about insulin resistance. So once you have given exogenous insulin, the insulin resistance that occurs in the adipose tissue, in the muscles, in the liver, does that happen for you to be able to get a benefit from metformin? So that's my other question. Thank you.
Okay, so carb counting. We have our own form of carb counting. In the face of the difficulties, you and your patients will try and come to something. So until we have a situation where you know that this weight of banku contains so many grams of carbs, this weight of yams contains so much. Until we get there, what we are doing is for the patients to be able to have the control of their meals. So that is why we educate them. Whatever food you eat, document it. So if whatever you took for lunch, breakfast, supper, document it. Because when they come, you are able to help them know. Because more often than not, they take the same amounts of the food that they eat. So you help them. You've realized that when you ever eat rice, your blood sugar goes up, right? Using the diary. So they are able to tell what foods give them spikes. So they get to know. So that they know that if I'm going to take banku, maybe instead of the 2 units I take for my meals, because banku spikes my blood sugar, I have to take an additional 1 or 2. You get it? If you eat, that is how we do it. If for some reason I'm in a festive mood and I'm going to take a large meal, I know that what I usually eat is not what I'm going to eat now. So I have to increase it a bit. So you know how we try and use our eyes to estimate things in our part of the world. We still do it with diabetes and insulin until we get to that point where we can do proper carb counting. We do that, yes.
Just for addition, yesterday we were sure that NCD is trying to work with FDA and all that to try and get our foods labeled. That's also another thing that will help us so that at least you know that this amount of carb is in this food you're going to take. Not what we are cooking at home, but at least for the ones we get from the shelves. At least that can also.
And also for your kind of patients, I know where you're coming from. The ones we get from the shelf, most of them, there are these apps that they can use. So one of them is the Secrets app. So most of the food, if you put it in, it will tell you how much carbs is in the fiber and all that content. So if they know their insulin sensitivity factor and they know the extra thing that they are going to eat, then they will know how much insulin insulin to take for that. So with the type 1 diabetes, actually, you can let them have a cheat day. Sometimes I tell them on your birthday, you can decide to have something, and then you just need to know your insulin sensitivity factor and then what goes into it. And it doesn't really give them that much spike.
So the second was about
About the metformin.
okay. Yes. Well, we use a lot of medications off label when it comes to children. But what's my experience with metformin in type 1 isn't much. I wouldn't say I know so much about metformin. But I have a patient who needed it. The insulin, I think this patient's background too was a problem. There was no food, family dysfunction. So her blood sugars were always very poorly controlled. And the diet was also not good at all. She was so wasted and had high blood sugars all the time. So what we tried to do was to, can you imagine, was on insulin of more than 4 units per kilo per day. Yes. So when we added metformin and improved the diet, we realized that the insulin, what you call it, sensitivity, yes, the requirements were coming down. So at least that is how I've used metformin. That's why I can say for metformin, it helped in that setting. And I don't know the details of what's being said about metformin and what they call type 1, like you were saying, but that is how I have used it. Yeah.
Was your patient obese?
No, this patient was wasted and requiring a lot of insulin. Very wasted, malnourished, in fact. Yeah. In fact, he was a walking skeleton. Yes. In fact, her face appeared in one of the pictures in the pictures Dr. Banker showed. Yeah, I wouldn't describe yours. She's the one. I had to bring her to my home, change her diet, and then manage the insulin for some time. About 3 months, she gets fine. She went back. Yes. No, but this child had been diabetic for so long. I didn't check CPD. She's been diabetic for over 15 years. But pardon me. Probably, maybe genetic testing would have helped.
Yes, I think a very good question that Dr. Adaya asked. And we sometimes see similar patients. Just recently, at the clinic, we saw somebody who is, I think, 19 years, has had diabetes for the last 8 years, from 11 years. Initial antibodies for type 1 diabetes were negative. The person is on metformin, plus some really high dose of insulin, basal, and then rapid-acting insulins. Now the question is, if you look at the person's neck, there seems to be some form of insulin resistance, acanthosis significans. So when the person was transitioned to the adult clinic, I had a difficulty. Is this acanthosis significans really there? And should the person then be on the metformin, or should we throw the metformin and just continue on the insulin? But the person was on high dose of insulin. The question is, sometimes if you maintain the metformin, somebody else may see sometime and they say, oh, this person is type 2, and withdraw the insulin, and then the person will go into crisis. So I decided to repeat all the tests and see. Now, the anti-GAD came negative just this week. Anti-insulin antibodies came negative. C-peptide came was very low. With the degree of the C-peptide being very low, I was convinced that it is the main driver of this high insulin requirement. Now, whether to stop the metformin because the person have an insulin resistance syndrome in addition, that was causing the acanthosis significans. I didn't want to take the decision alone, so I decided for a team review. I called somebody to look at the neck, and I called Dr. Waye to also look at the neck. For us to convince ourselves in this area and that area, are we convinced about this insulin resistance? Because C-peptide is really low. But 10 years on after diagnosis of diabetes, anti-GAD, which is the most common, 70% of the time positive, is still negative, and anti-insulin. Those two are not the only antibodies. There's anti-zinc transporter 8, other antibodies are positive. There's about 10% of patients with type 1 who will never get antibodies. Majority will have antibodies. So in that instance, it becomes a bit tricky sometimes how to manage our patients. But by and large, I think they require a lot of insulin. whether to add a metformin and somebody else not stopping the insulin and saying, oh, this person is type 2, let's do only metformin and plus orals, and the person getting into maybe some bad decay and then coming some sequence. I think that one, everybody can discuss how to go around that difficult area.
I think I know the patient you're talking about. And so for her, it's the same patient, right? The one I called you. Yeah. So for her, she has a strong family history of diabetes. So at diagnosis, we did the antibodies and you've repeated it and they were negative. So she came in quite obese, like her BMI was above 20 at that time. And then she had the insulin resistance. It's the same patient. She had the acanthosis and all that. Okay. So at a point, I told her that if she's able to bring her sugars down, we'll go off the insulin and see what the metformin does. And this is something to us all who treat adolescents. What she started doing was recording hypoglycemia. So her lows can be 0.7, 0.1, and they were not real lows. So I asked her to do an HbA1c. And she did the HbA1c, which was 17 point something. And she scraped off the 1 and brought 7 point something to me. That day I could have made the residents see her, but I had known her since she was young. So I saw her pass and I was like, I'll see you today. And I just picked the paper and my eyes went on the millimole, which wasn't correlating to the 7. So she is, sometimes I wonder whether there's a little bit of genetic thing because I knew that the mother had it and the mother died quite young. So I understand where you guys are coming from. The acanthosis have been there since. She loses weight a little bit, then she gains. She will lose weight when she sits in the highs. So she's consistently have her HbA1c above 10 for the past like 4 years, despite what you do. But she'll bring you readings of 0.7, 1.2. And she'll tell you her glucometer is missing. All the best.
A very difficult patient because the most recent HbA1c was 13%, 13.5 HbA1c. Meanwhile, when she brings you the glucose profile, you see a lot of under 4s, 1.2, 1 point something. The HbA1c is 13 point something. It's tricky.
She's finished SS. She just finished SS. That's how come I transitioned her over. She just finished. Yeah.
Okay. Please, any further questions or additions, contributions?
Okay, so thank you, Dr. Leila, for the presentation. I wanted to ask on the fluid rehydration for DKA. So you mentioned that when they come in shock, you should address shock. And then we also know that when they come in significant DKA, we're supposed to consider some 5 to 10% dehydration deficit and then address that. Now my question is, when they come in shock and you address shock, we know we don't go more than the 10, 10, 10, 3 times. Are you supposed to take out your shock boluses from the rest of the rehydration? Okay, now the follow-up question is, when she's out of shock or when the patient is out of shock, what happens to my deficit?
So the deficits you calculated. So let's use the 20 kilo chart. So 10% of 20 is what? 2, isn't it?
Yeah.
So we assume that the patient has lost 2 kilos in the form of water. And so that will be 2 liters. Do you get it? Physics. Every weight will displace the same amount of water that you put in it. So 2 liters. So 2 kilos is what you've lost. And then it translates into 2 liters. So we add that to your maintenance requirements for over 48 hours. So if you require, the child is 20. If you calculate the maintenance requirement, say it's 1.5. For 2 days, it will come to what? 3 liters. So you add the deficit of 2 liters, you get 5. So you are giving these 5 liters over 48 hours.
Okay, all right, thank you very much.
Okay, seems there's no further questions. A round of applause for our panelists.
Come back for the AGM after lunch. Tell them they have to come. To get their certificates, they have to come for the AGM.
Yes, has it distributed the teeth? Okay, so it's time for yes, it's time for lunch. Kindly pick your coupon on your way out. And please, after lunch, don't go away. So AGM, annual general meeting, scientific is finished, but the meeting is going to be held right after lunch. And I thought it should pick it. Okay. So right after lunch, we'll have the AGM. Remember that we are going to have elections as well. So please kindly stay. And it won't take too long a time. We'll be done. Yes, just a short AGM. We'll tell you our financial statements and everything. Please stay. And then we'll be gone pretty soon. Thank you all for sticking and staying with us. Lunch is for 30 minutes.
30 minutes. Let's make it 20 minutes.
30 minutes, and then we are back. Please don't run away after lunch, we beg. We remember. We remember.